I will not waste much of the time. Would like to call Dr. Jimit. I am Dr. Chandni and this is Dr. Kinjal. Dr. Jimit is from Surat. He's a consultant endocrine from diabetes metabolic physician at Surat. Many co-authors at RSSDI guidelines, executive editor and progress in medicine. He's from TS. He has also won a national award in 2016 at TYCA, member of American Association of Clinical Endocrinologists. His topic for today is insulin during travel, post-transplant, on steroids. Dr. Jimad, I hand over your session.
Thank you, Dr. Chandni, and thank you, Dr. Manoj Chawla, sir, and Dr. Purvi for inviting me here. So we are starting with a wonderful insulin workshop, and I'm sure you'll be having uh, so much questions also about insulin, and there are different topics in this workshop, and the question answer is at the end, so you can interrupt me also in between. So I will be talking about three important aspects which are mainly patient related, and one aspect that is doctor related also. So travel, post transplant, and when we give steroids. These are the three tricky parts in insulin management, and that's why we'll be looking after these three parts. So traveling, we know it is very important thing. One key aspect is also transportation and storage. So storage becomes very, very important because we know insulin being a complex protein and very, very temperature sensitive molecule. So once the temperature increases, it loses its potency. So that's why the maintenance of cold chain is very, very critical during traveling. And the storage part, very important thing. The common mistake what we do is we place insulin directly on the ice cubes or directly to the ice packs. So this is a mistake because majority of time what will happen, the surface of insulin which is in direct contact with the ice will be definitely we go below 2 degrees Celsius and will have losing its potency. So never put directly insulin vials and cartridge to the ICs or ice pack. Similarly, when we are transporting it immersed in water also, or once the ice becomes melted, it destroys the label on insulin vial. So this is again a second mistake. So always we have to have an insulated bag or cooling pouch which is ideal for transportation for insulin, and we should avoid sudden temperature variations. There are many commercial available pouches are also available. Similarly, we have we can if you want to transport longer, we have plastic boxes like this, and which have ice in below and above, and in between there is a cotton layer and a waterproof layer. In between them we can store insulin, which is the one of the ideal one for shorter duration of trans. We have some of the gadgets and pouches available commercial in India also. This is one of the simple pouch which is available in India very widely, and you can use. I've hidden the brand name, but you can find any of them. So it works. It has a crystal pouch, you can see here. It works by mechanism of evaporating cooling. Once you dip it inside water and you let it activate for 10 to 15 minutes, it becomes activated and its temperature goes down, and it maintains its temperature between 18 to 26 degrees for up to 45 hours. So at least minimum one day your patient is free of any tension of losing the cold chain. So this is very practical and simple solution when we are traveling with insulin, and we should strictly monitor the immersion time. We should always avoid over soaking, otherwise it will become unusable, and it is reusable also. Once your travel is over, you can just simply make it dry and it is ready for the next use. Similarly, for road travel and rail travels, always, as we have discussed, keep in a flask with high or with a handbag. Okay, once you keep in a car, so common mistake what we do is we keep the insulin, okay, in the glove box. Okay, driver side, the co-driver side, there is a compartment which we call glove box. And very critically, if you park the car with AC switch off, okay, in summer your car's temperature go high up to 40 to 50 degrees Celsius, and it instantly denatures the insulin. So avoid keeping insulin stored in the car's glove box, which is one of the common mistakes. Similarly, air travels, very, very important thing, we should ensure sufficient injection supplies. Why? Because we see lots of time that baggages are lost, okay, or baggages are delayed. So ensure you have enough supply when we are traveling abroad. In air travel, advise patient to carry doctor's prescription and certificate, which is again a critical. Time zone changes, we will see about how to do time zone changes and changes in the basal insulin time. And it should be never be placed in baggage hold in the plane or the check-in bag. Simple words, because the temperature when the flight is at the very high altitude, the temperature in the cab, the check-in baggages can go to freezing also, and this will denature the insulin. And avoid, it is advisable for patient to have pens and cartridge to carry, and no, especially a spare one, to ensure uninterrupted insulin supply in the event of either a pen is broken or malfunctioning, or it is lost very commonly. So if you are traveling a long international travel, and when we are switching time zones, so there is one of the important thing, when to take basal insulin. Okay, travel, it is again a very important thing. So uh, when we are traveling east, okay, and we are switching approximately time zones or more, what will happen, the day will actually shorten. The time, they will not shorten, the time zones they change. So actually we will see lesser daytime, and we may need a reduction in the long acting basal insulin dose. Okay, suppose you are traveling to east, and the time zone difference is, suppose we take 5 to 7 hours, and when you reach there, you will be seeing already the evening or the night time has already come, and your basal insulin time is actually earlier, even if you have taken the insulin at the regular night time in your home country. So what will have to you have to do, you have to reduce the dose of basal insulin on the first night at the travel country, and the second day you can continue with the same insulin doses and same timing at the newer zones. Similarly, if you are traveling westward, what will happen, the day become longer. Okay, you fly in morning, and you will also end up in morning or afternoon only, even after 8 to 10 hours. So this means you need to take an extra doses of rapid acting insulin or shorter insulin. Why? Because the basal will have lost its no effect. Suppose you are taking glargine, the effect will be gone mostly after 18 to 20 hours, and you are still further improving the you are still delaying the next basal doses. So what will happen, there will be insulin free time. Okay, and especially in type 1 diabetes, it can start ketogenesis. So you have to take an extra shorter acting insulin in between. And we have now general second generation basal insulin. So switching to this, or patient who are already on this basal insulin, you will have an advantage because of added extra half life. So another thing will happen in traveling is the during the flight multiple meals are served. So patient with type 1 diabetes, especially for them, you have to take extra injections, and patient should inject rapid acting bolus insulin with any meal that contains carbohydrate, for especially for type 1 diabetes. Coming to second part, transplant and diabetes. So majority of these patients after the organ transplantation, which has picked up in our country now because of more and more awareness, we are seeing more transplant cases, we are getting references for transplant and diabetes. So majority of these patients are renal transplant patient in my point of view in India, and majority of them are diabetes, because we know diabetes is number one reason for CKD and transplant in India and across world also. So majority of these patients are having diabetes prior to transplant. This makes the major chunk. Then second thing, hyperglycemia occurs immediately following transplant, which we call transplant diabetes, stress diabetes, steroid associated hyperglycemia. So it is stress from surgery also, high dose steroids also, and changing steroid regimens. And diabetes risk after long term following the transplant. So this is a new term, new onset diabetes after transplant. So this is not, or this is different from acute hyperglycemia immediately post-op, but it is longer, long-term follow-up. You continue the follow-up of the patient, and you find new onset diabetes, which we call NODAT. And these are the risk factors. So, what are the treatment options? So, post-transplant diabetes is an important contributor, very important to mortality of renal transplant patient. And effective management is very profound improvement in long-term outcomes after kidney transplant. The critical part is insulin therapy, because in early post-operative phase, if you start insulin treatment, you have beneficial effect. You will see the advantages of using insulin in post-transplant diabetes earlier to have protective effect on beta cells also. And beyond the early post-operative phase, we can start oral anti-hyperglycemic agent, and later on we can continue on oral also depending upon the patient profile. So in 2014, there was an international consistent guidelines for screening, diagnosis, and management of post-transplant diabetes. We'll just focus on treatment. So initial 1 week insulin is the choice. From after 1 week, you start insulin, you continue insulin also, and you try to add oral anti-hyperglycemic agents also. And for post-transplant or NODAT, lifestyle modification is first. Later on, we can start with oral anti-hyperglycemic agents and insulin as we go for type 2 diabetes. ADA also recommends that after insulin therapy is the agent of choice for management of hyperglycemia and pre-existing diabetes and diabetes in hospital setting, and it can be continued post discharge also. So insulin is must. What about RSSDI recommendation? So similar recommendations are from RSSDI also. Early post-transplant period, insulin is the only safe and effective agent due to high glucocorticoid doses and acute illness. Immediate post-transplant hyperglycemia, okay, reverse the sequence of management. You have started with insulin, we can switch on to by adding oral anti-diabetic agents and along with lifestyle modification as and when the fitness of the patients permits. And for late post transplant diabetes or NODAT, lifestyle modification is first, followed by oral treatment, and then insulin and appropriate option like we treat our type 2 diabetes patients. So RSSD has mentioned the evidence is also like Hacking et al. Has shown that early insulin reduced the post-transplant diabetes by 73% patient in renal transplant patients. Similarly, Harmeyer et al. Shown intensive glucose control with IV insulin immediately post-transplant with uh, with as compared to subcutaneous insulin showed no difference in delay in graft function. And intensive control was associated with greater risk of rejection episode and hypoglycemic events. So this was the contrary, but majority of guidelines suggest you start with early intensive insulin treatment. Similarly, for heart transplant patients, this was a retrospective study where IV and subcutaneous insulin protocols with glucose target of very strict control were found to be safe for cardiac transplant patients, for both patient with and without pre-transplant diabetes. So insulin is the choice as we have discussed. This is again a similarly study from uh, American Journal of Nephrology, where it clearly says if you start early insulin, you have your lesser chances of post-transplant diabetes even after discharge in future. And early basal insulin treatment decreases the new onset diabetes after renal transplantation. So, what to choose? Majority of the time, a basal bolus regimen is most effective management approach. But the nephrology guidelines says the standard regimens, basal, split mix, basal bolus, all are applicable. Okay, but the basal bolus regimen is favored and most effective management approach in inpatient hyperglycemia in renal transplant patient. Coming to the third part, steroid induced hyperglycemia. We know it is one of the most uh, commonly occurred drug induced diabetes and drug induced hyperglycemia in clinical practice. The reason that steroids, glucocorticoids directly affects the pancreas. It increases the glucagon, reduces the insulin secretion from beta cell. It impairs incretin effect, and later on in muscle also it reduces glucose uptake and increases proteolysis. Similarly, in uh, adipose tissue, it reduces insulin sensitivity, increases resistin and leptin also. This is why this hyperglycemia is there. So what to do? We want to prevent, we should educate and preempting the inevitable, and you should screen also letting teams know. Okay, you any treatment of glucocorticoids by no surgeons or rheumatologists or anyone doing the treatment, you have to inform your team that sugar is going to increase, and that's why you can screen when it happens, treat early. So it can be how sugars can increase with steroids. We know it, either chronic use of steroids leads to diabetes, common one. Second, use of steroid in patient with pre-existing diabetes which derange the glucose control. And sometimes there is increased endogenous secretion of glucocorticoids like Cushing's. So these are the commonly used steroids. due to lack of time, I'm skipping the details. But the treatment protocols, how to adjust the insulin when we are using different kind of steroids. So the commonest steroid is found in clinical practice is single morning dose of prednisone, usually by the rheumatologist or sometimes the transplant patient. They are taking single dose of prednisolone in the morning. This is the commonest prescription. So hence the what happens to blood sugar level when you give prednisolone? The blood sugar level increases in the morning, okay, and it reduces by late evening. So there is a peak around 11 to 2 p.m. and it gradually peaks is down, going down by evening. So we have to choose an agent which has similar anti-hyperglycemic effect. Hence, so what is the ideal insulin therapy? Sometimes we can use oral treatment also, like gliclazide. Immediate release gliclazide is also used. We have seen so many evidences. So insulin treatment, we can use intermediate acting insulin, NPH or datamine, and we should administer at the same time as dose of prednisolone, because the action profile of this NPH insulin and the single dose of prednisolone is similar. So if you are using prednisolone or methylprednisolone small doses in once daily doses, what should be the starting dose of NPH insulin is zero point 0.5 unit per milligram of prednisolone. It can range depending upon the patient's profile, and if the prednisolone is given 2 times a day, we can use twice daily. Similarly, if we use dexamethasone, which is much more potent and longer duration of action, we have to give NPH 3 unit per milligram of dexamethasone. Similarly, if you are using basal bolus treatment, we increase the dose of basal bolus therapy, total dose by 140 to 150. For hydrocortisone, which are given once daily only, or the state doses, or sometimes no, one doses of hydrocortisone, sometimes like extubation, sometimes for any breathing difficulties. So NPH we can give 0.125 unit per milligram of hydrocortisone. Similarly, if you are giving hydrocortisone twice daily, use it the same dose as twice daily administer. Patient taking multiple hydrocortisone doses, dexamethasone doses, or methylprednisolone pulse therapies. These are the higher potency doses, which definitely deranges glycemic control in your type 2 diabetes, and hyperglycemia is severe also, and hyperglycemia is prolonged also more than 24 hours. So best thing is the using a basal insulin or multiple daily injections. So simply you put them patients on basal bolus insulin treatment. Patient again, if basal insulin is already going on and you start this treatment, you increase the dose. Similarly, in acutely unwell patients, after intravenous insulin infusion is required for short duration. So suppose your patient is put on methylprednisolone 1 gram for 5 days, and patient is already uncontrolled, you'll find the blood sugars will go haywire, 300, 400, 500. So you should anticipate that. Okay, your treating primary consultant should inform you that it is going to start. You start checking, and your initial step in my all patients is IV insulin infusion, because it is safe also, it will be effective also, because majority of patient, if you put on subcutaneous insulin with this pulse therapy, sugars will not get controlled in the next 1 to 2 days. So ideal choice is start IV infusion in this patient. The second advantage would be you will get the total insulin requirement dose also. If you continue infusion for 24 hours, you get the dose this patient requires, total insulin these units during first 24 hours, and later on from the next day you can switch them to basal bolus insulin. Suppose patient required 60 unit, so 30 unit you can give as basal, and 30 units pre-meal you can divide into 3 injection. Similarly, when we are tapering the doses of steroids, you have to reduce the dose of insulin, otherwise your patient will go into hypo, and this is very common in OPD based practice. So you should explain your patient to check and revert back to you. Similarly, insulin during type 1 diabetes patient getting steroid, this is a similar one. Patient on type 1, my all patients are usually on basal bolus only. So simplest thing is you increase the dose of all the insulin, all the doses by 10 to 20%.
Thank you, Dr. Jimit, for a lovely lecture. Moving on to moving on to the next topic, I'd like to call the next speaker Dr. Vipul Chauhan. Okay, he's a diabetologist in Ahmedabad. He's going to take a topic on cases of initiation of insulin in type 2 diabetes.
Yeah, thank you so much for kind introduction. At the offset, I would like to thank Dr. Manoj Chawla sir and Purvi ma'am for amazing and wonderful meeting of WCPD and DRS. And I'm happy to be a part of insulin workshop always because it is something that is very much lagging in our country. I would say we are moving from glucocentric approach to glucovasculo adipocentric approach, but still sometime in a jest of preventing complication, we forget that glucose control is a primary and at most important thing. There are three kind of people or diabetic population in our country. One who are not diabetic or pre-diabetic yet to become in the pool of diabetic. Second, people living with diabetes. And third is who are on insulin. So we see them as a some separate species or separate entity. People are scared that once doctor will put them on insulin, their life will be different and they will be out of their independency. They will be dependent on many things. And secondary, there is some guilt that they have failed to control their glucose in adequate level. And as a punishment, doctor has put them on insulin. So today it is a workshop. So I would not use much of my slides, but I would take audience opinion that when should we start insulin? Today we are talking about type 2 diabetes specifically. So when should we start insulin in type 2 diabetic patient? Any opinion from audience? Can we start insulin when patient is on steroid? Can we start insulin when patient is on end-stage kidney disease or in dialysis? Can we start insulin? Yes, sir. Exactly. So from very first day, there are some indication that we should start on insulin therapy. And we have to explain our patient when you see them for the first time in your OPD that insulin can be start at any point of time of your natural course of disease of type 2 diabetes and it can also be stopped. Many a time patients are scared like एक बार इकोस्प्रिन डॉक्टर ने start कर दी तो nobody dares to stop it. Someday somehow there is a episode of severe gastritis or pancreatitis or anything and that gives some T wave changes in the ECG and some over enthusiastic fellow start on ecosprin and then the patient has to take it for rest of the life. Likewise, the insulin therapy initiation is important, intensification is important, and also de-intensification is also important when we start in our insulin naive or even drug naive type 2 diabetic patient. So let's see today the timely initiation of basal insulin in type 2 diabetic patient with inadequately control on OAD. Now this is a very debatable area. How will you say that inadequately control on OAD? So how many OAD should be there? Yes. Again, this is a catch. It is absolute indication when there is three OADs are going on in full dose and there is a not good glycemic control, you should start insulin. But even at the with one OAD, even with two OAD, when there is severe degree of hyperglycemia, we have to start with insulin therapy. We are talking about time in range. We are talking about glycemic variability in a day that in 24 hours more than 17 hours should be in the time in range and there should not be too much glycemic variability. But when are we are talking about time in range in terms of weeks, days, months and years, and actually they are leading to many complications. So time in range should also be seen over weeks and months. One HbA1c is more than 9, you are up titrating OAD, you are waiting for 3 or 6 months, and that hyperglycemia will not harm patient, they will not cause macrovascular disease or microvascular disease. So irrespective of the OAD, irrespective of the time of duration of the diabetes, if there is a bad glycemia, we should start insulin therapy. Like we are seeing this garden variety of patient 63 male diabetes since long duration without any comorbidity, without any complication at present, just presented with severe degree of fatigue and he is not happy with his life, he is not able to carry out his daily activities. When we evaluate him, he was on metformin 500 twice daily, glimepiride 2 milligram once daily. There is no hypertension, no ASCVD. Patient did not do exercise regularly, living sedentary lifestyle. But I think 95% of the Indian populations are like that, who are in minority, who does regular exercise and follow doctors and dietitians advice. Patient was a smoker and type 2 diabetes, uh, taking uh, two tablets only, metformin as well as glimepiride. On examination, BMI was 25, not too high, not obese actually. BP was normal, pulse was normal, systemic examination was absolutely normal. There was a peripheral neuropathy in terms of bilateral sensory loss in lower extremities. Now let's see the parameters. The fasting sugar was 220, postprandial was 310, HbA1c was 9.4, blood urea nitrogen, serum creatinine, echo, urine microalbuminuria, fundus, everything was normal. So now what and how will you manage this patient? So we are scientists, we are clinician, we have to see the evidences. What are the guidelines suggesting? The guidelines saying the HbA1c of persons should be less than 7. Fasting capillary plasma sugar should be between 80 to 130, and peak postprandial capillary glucose. Mind you, it is not 2 hour glucose. It's peak postprandial capillary glucose. It should be less than 180. And this target has to be achieved in this patient. So what will you do? Again, it is an area of debate. Patient is on sulfonylurea, patient is on metformin. We can put him on GLP-1 RA, we can give him SGLT2 inhibitor, we can give DPP4, pioglitazone, acarbose, and whatnot. But again, the question is on how long duration you want to control that hyperglycemia. Yes, of course, there is a chance in his lifetime that you will add GLP, you will add SGLT2, you will add X number of medicines. You can also give hydrochloroquine. But to control this hyperglycemia, fasting more than 200, pp more than 300, A1c more than 9, you have to decide that it should be controlled within 10 days or 15 days. When we start basal insulin, we monitor fasting sugar every alternate day. Do we do with any other medicine? No, because we trust insulin. Once you start 10 unit or 12 unit or 20 unit, it will bring down fasting glucose very fast. And according to that fasting sugar, we have to up titrate or down titrate the scale. So let's see how cumulative evidence supporting the early insulin initiation and the evidences from India itself, from Dr. Manoj Chawla, Dr. Makkar sir, Dr. V. Mohan sir, and they all say that early insulin initiation gives good glycemic control as well as good durable glycemic control. And once you have achieved this glycemic control, you can now taper off the insulin, as well as you can add glucovascular adipocentric medicine, you can add GLP-1, you can add SGLT2, and whatever you find feasible for your patient. So now let's case the continue. Now he is ready that clinician is convinced that patients should be put on basal insulin for shorter duration of time. But this is a half part of the story. The movie is in interval. Picture abhi baki hai mere dost. How to convince your patient to take insulin? There are many barriers to insulin therapy, and most important barrier is clinicians' inertia. And I guess I overcome with this discussion that now we are convinced that any point of time in type 2 diabetics, when there is severe degree of hyperglycemia, we should start insulin. But let's see the patient oriented barriers. Fear of lifetime commitment to painful injection. Again, I already said that once you put in patient on insulin, explain that it is a shorter duration of time. Once your glucose are under well control, we will take off this insulin, and then patient will be relaxed that they don't have to take insulin for lifelong. The complexity of treatment regimen, explain them. It is a basal insulin. It will not cause hypoglycemia. It is to be taken irrespective of meal time and single shot of your convenient time. Then the complexity is out of question. That is misperception, like linking insulin with poor prognosis. We use insulin as a gun. We put on patient's head and say कि अगर अच्छा कंट्रोल नहीं आया, नेक्स्ट टाइम अगर ये नहीं किया, मैं तुझे इंसुलिन पे रख दूंगा. And then patient subconsciously develop fear for insulin, that when you actually start insulin, it is a punishment for them. They have failed to control their glucose in a proper way. So we have to educate them. Insulin is very, very important, and it should be used whenever it is required. High cost of treatment. Actually, in this era, it is not a question that if you are giving insulin for a 1 or 2 months, it will not cost more than 2-3 thousand to the patient. So how to overcome barrier to the insulin initiation? We have to explain that the damage done by hyperglycemia will be lesser, or the pain with insulin is lesser than the having CKD or ASCVD or some peripheral neuropathy or amputation or retinopathy. We have to overcome with a positive solution that insulin should be given with 31, 32 gauge needle, and it is extremely painless. In our clinic, me and Dr. Dhruvi most of the time give first shot in our presence, and patient feel that it is actually painless. difficult to use. Dexterity is very, very important. Patient is 60, 65 years of age. They haven't used any gadget with their hand. We have to give them pen in their hand, disassemble the cartridge, pen, needle, everything, and then reassemble and take first dose, dialing 10 unit. Then again, we have to tell them to dial to 20 and go back to 10. You can go back. It's not necessary 20 dial ho gaya to wohi lena padega. Then that will help to the patient. The complexity treatment is not that in basal insulin you have to single shot at any selected time and misperception linking insulin with poor prognosis. No, it is not that. It is helpful for management of type 2 diabetes in a good way. This is also a paper that shows initiation and intensification of insulin therapy in type 2 diabetic. What are the barriers and solution? And again, this slide or this insight study shows that when you put patient on insulin, you achieve good glycemic control early, as well as the durability is also there, that patient remains in good glycemia for longer duration of time with good HbA1c, good fasting sugar, and good postprandial blood glucose levels. So now the third question is what dose to be started. The dose of insulin depends on two things. First and most important is glycemic status. We have to see whether HbA1c is less than 9 or HbA1c is more than 9. Simple thing. And second is weight of the patient. If the HbA1c is less than 9, you can start with zero point 0.2 unit per kg of basal insulin. And if HbA1c is more than 9, you can start with zero point 0.3 unit per kg of basal insulin, multiply by the weight of the patient. Like in this patient, we consider the weight as a 60 and A1C more than 9, this patient should be started with 18 unit of basal insulin. So again, let's continue this case. The initial dose was decided as a 18 unit glargine at the predefined time. Metformin was continue. Glimepiride can be continue. It is also debatable, but not at this time because we are lacking the time. And mainly self-monitoring of blood glucose is explained. Here most of the time we fail. We start insulin but we do not educate, do not empower our patient, we do not give power to change the dose to the patient. In what fear I don't know, but we have to educate them. Okay, see the fasting sugar, up titrate or down titrate your insulin dosage. So this is the patient's parameter after 3 months, the fasting from 220 to 110, ppg 310 to 140, HbA1c 9.4 to 8.3, and serum creatine and BUN are normal. So I think almost we achieved what we want. And in gradual time, the HbA1c will also be less than 7. So this is a success story of this patient, that early initiation of glargine effectively controls patient fasting as well as postprandial glucose. Now again, there will be debate whether we should start with a basal insulin or we should start with the premix insulin. Here I have some personal opinion that we tag many things very fast. We are country, we are Indian, we have a history of 10,000 years. We were under Britishers' rule for less than 190 years. I think it was only 100 years we were under their rule, but still we celebrate Independence Day since 80 years. We were our own country. 100 साल का गुलामी वो गुलामी नहीं है. We have not tagged that we were getting independence from Britishers. We should not celebrate for more than 100 years. Likewise, we stand that our country is a premix country. We are using insulin since 50, 60 years. Yes, we were using premix insulin, but now we are changing. We are changing to the newer molecule. We are changing to GLP. We are using GLP insulin combination as well. And very soon we will have the costliest molecule for the management of diabetes in our country. So we should not stand that we are a premix country and we should be feel free to use basal insulin or even co-formulation or even rapid acting insulin at initiation whenever it is required. And what are the taboos that we know, that when we start insulin there will be hypoglycemia, there will be weight gain, there will be hypoglycemia, there will be weight gain. It is because of premix insulin. There are so many data from glargine, from degludec, from glargine U300 that they do not cause weight gain and significant degree of hypoglycemia. So I think basal insulin is the only choice and we should use for our patient. I would not say you the drawbacks of premix insulin, but I would say that when you use basal insulin, the fasting element will be out of the question and it will reduce the fast basal or fasting as well as postprandial insulin level. Now I have only 1 minute, so I will very rapidly say that there are 7 vital T's for basal insulin in type 2 diabetic. First and most important, treatment initiation. You have to start somewhere, not waiting for 3 OD to fail, not letting any complication to happen. Whenever you see there is severe degree of hyperglycemia, put insulin for a shorter duration of time, and whenever there is good glycemic control, you can withdraw it. Timing of administration, basal insulin can be administered at any convenient time of the patient and irrespective of the meal timing. Technique of administration is very, very important. We have 32 gauge needle. We have to inject at 90 degree. We did not have to pinch the skin. We have to educate the patient, because for you, you will start insulin 10 patients a day, 100 patients a month. But for them, it is a lifetime first thing that you have to explain and educate. Transportation and storage, Dr. Jimit has wonderfully explained us. Tablets, yes, we have to up titrate and down titrate the oral therapy according to the patient's age, patient's duration of diabetes, according to patient's comorbidity, and any complication if there at that time. And target for titration. Whenever there is a fire, you cannot only throw one bucket of water and wait fire to end. You have to throw a second bucket, third bucket, and more water will be required. Like in insulin therapy, starting 10 unit or 18 unit will not be adequate. According to the hyperglycemia, you have to monitor the sugar and up titrate and down titrate the therapy. But you need to have predefined targets for the patient. That this patient requires fasting 90 or 100 or 110 or 120, depends duration of diabetes and comorbidities of the patient. And tool for monitoring and troubleshooting. In this era, we are living in a technology, we are living in AI era. At least we can provide some backup WhatsApp number to our patient, that if there is any difficulty, you can contact us here. And for monitoring, we have implantable sensors to a simple glucometer. Everything is available. We have to just educate and empower our patient. So starting the insulin is just beginning. We have to up titrate, intensify. We can get to basal plus, to basal bolus therapy, and it is a continued process for the patient. So time is up. I will not spend more time. So we are starting the campaign called Insulinization for India, like vaccination for India. We are in era, we are living in a tsunami of type 2 diabetes. We are developing diabetes in teenage, 20s and 30s. So if we not start insulin at a correct time, after 10 or 20 years, there are people living with complications of diabetes. Right now, we are talking about diabetes prevention and reversal. After 20 years, we will be talking about prevention of complications of diabetes. So if that we not want to happen, we have to join hand with each other, and we have to start insulinization for India. Once again, thank you all for your silent listening.
Thank you, Dr. Vipul. It was really a power packed session. Questions we'll take later on. Moving on to the next session, Dr. Anushri Mehta from Mumbai. She's a consultant diabetologist, also working at Ramakrishna Mission Hospital attached to Arogyanidhi. Her topic for today is newly detected type 1 DM 11 years. How to start insulin therapy. Dr. Anushri, I would.
Thank you, Chandni. I would like to thank Dr. Manoj and Puri Chawla for giving me this opportunity to be part of the WCPD DRS extravaganza that we've been attending for the past 2 days. So, my topic is newly detected type 1 diabetes of 11 years, how to start insulin therapy. I have not kept any trials. This is very, very pure clinical presentation, and I probably might cover up for the time. So, so don't worry. So, whenever we come across a child with type 1 diabetes, the first question that we have to answer, or the first decision that we have to make, is which insulin to use, in what dose, and education is as much a part of the treatment. Monitoring is as much a part of the treatment as is the insulin. So if you're only giving insulin, if you're only prescribing insulin, not giving an education, not asking them to monitor their blood sugars, then it's a half treatment. It's not complete treatment. So I will probably repeat this couple of times during the presentation, that there is no role of any premix. The only regimen that should be used, whether the child is rich, poor, middle class, doesn't matter. The only regimen that should be used for a child with type 1 diabetes is a basal bolus regimen, 4 injections a day, maybe more, nothing less. Okay, so nothing, no role of any premix. If the child is on premix, we switch them over. And this is a newly detected child, so the ball is in your court. You can pick and choose your choice of insulin. So we have a lot of choices for basal insulin available in the market nowadays. You all are very well aware. We have prandial or bolus insulin available. Depending on the patient's pocket, you can actually select the type of insulin you want to give to the patient. And nowadays, even glargine is under the DCGI. They've price capped it, and it's quite affordable for most of the patients. Earlier, maybe a couple of years ago, the child or the schedule and the food of the child was actually catered to the insulin dose. But we've seen a switch, we've seen a 180-degree switch, and now we first take the schedule of the child into consideration and then give the insulin to the child. So let's have a quick look that whenever we give basal bolus, you can see here that we expect the basal to work for 24 hours. It's peakless, and if it's given in the right dose, it shouldn't cause any kind of hypoglycemia. And every time the child eats, as the physiology goes, they require a bolus of insulin. Okay, now this bolus can be a regular insulin, or it can be an analog insulin. Okay, but if you give an analog, the analog will only cover for the meal before which the insulin is taken. It will not cover for any extra snack that is taken in between meals. So we have to take the schedule of the child into consideration. We'll come to that. And this graph here, you can see this is regular insulin. So you can see that it acts for 4 to 6 hours and it peaks at 2 hours. So whenever the child is on a regular insulin, you have to make sure that at the time of the peak, so at 2 hours, the child is given an extra snack. Otherwise, there is a very high risk of the child developing hypoglycemia. Okay, so if the child is reluctant to have an extra snack, or if the child is not very regular with the food, then you can actually prefer to switch them over to an analog insulin over a regular insulin. That will work better for that particular child. So for this child, we'll say this is a typical schedule of a 11-year-old. They'll have breakfast in the morning, go to school. In school, they may have a break where they may have a snack or they may play, right? So we don't know if they're going to eat the snack or not. So we take the history from the parents or from the child that, okay, what is it that you want to do? Do you want to have a snack in school? Do you feel hungry? If they do feel hungry, then you'll probably give a regular insulin, which will cover for the snack in the school. If not, then you can give a rapid acting or an ultra rapid acting insulin. Then they come home and usually have lunch at home. They have morning school, or if they have a full day school, they may have a lunch break in school. And if they have a lunch break in school, they have to take a bolus in school before lunch. There is no leeway that lunch requires insulin. No premix is going to cover for it. No NPH is going to cover for it. No jugaad will work. No AGI, no metformin, nothing. You have to give a bolus for that lunch, if at all, if it is in school. At home, it is not a problem. They usually are ready to take their pre-lunch bolus. Okay, and then you have maybe a rapid and ultra rapid before dinner. Now, this evening snack is always a googly. I think even when we treat our type 2 patients, the evening snack is always a googly. It's usually vada pav, dosa, and whatnot. Okay, so it's a similar problem even with our type 1 kids. So again, now if the child, a lot of children don't prefer an evening snack. You'll be surprised because they come home late. They come home at 2 o'clock, they have their lunch, and then 8 o'clock they have dinner. So they don't prefer an evening snack. So we can actually ask them to skip the evening snack. We can just give them a rapid or an ultra rapid acting in the afternoon. But if they do want an evening snack, we have to give a regular insulin so that it will cover for the evening snack, because it's a longer acting, as I showed here. So if you to give it at lunch, it will cover almost, at the extra snack at 4 or 5 o'clock. Sometimes if the evening snack is very large, or if they are not consistent with the evening snack, again, a rapid acting or an ultra rapid acting insulin gives them a lot of flexibility, and they can just take the shot when they have an evening snack, and they can skip the shot when they're not having an evening snack. So cost is always an issue in our country, and we often come across patients who cannot afford even the currently low priced basal bolus regimens. So we still have human insulins. We don't need to give them premix. They work equally well. We just have to teach them how to mix the insulin in the syringe. Dr. Vipul Chawda mentioned about dexterity, which is not a problem with children. They are much more flexible. Their vision is much better than our vision. So that is usually not an issue. Just have to teach them how to use it. They learn the skill very quickly. An 11-year-old child is very well, equipped, has enough IQ to take their own insulin injections, should not be an issue. So we can give them something that we call as a split mix, which was being used before the basal insulins came into the picture. And you give NPH and regular insulin, and they can actually be mixed in the same syringe while before taking the insulin injection. So we usually split the basal or the NPH and the regular insulin in 50 to 60%. So 50% would be NPH, 50% would be basal. Sorry, 50% would be regular, and we try to give 70% of the NPH at bedtime, and the remaining 30% you can give in the breakfast, because the daytime you're taking regular insulin, so it can actually cover up for the NPH whenever you have gaps. So the regular insulin covers up for those insulin free periods, and that's why you give lesser dose in the morning to begin with. Then you have to adjust according to the patient's requirement. You give more in the night. So if the child is admitted and you've given IV insulin, so the rule is that whatever total insulin that the child required over the last 24 hours in the IV insulin pump is what is the total daily dose. You calculate, for example, if she required 40 units of insulin over the last 24 hours, I'll split it into 50-50. I'll give 50% as basal, and the remaining 50% I will split into 3 doses before every meal. Generally, in the beginning, they require higher doses, and as the sugars come under control, on an average, most type 1s require anywhere between zero point 0.7 to 1 unit per kg. That is the usual average requirement for most kids or adults for that matter. Uh, at this stage or at the first visit, it is very vital that the family is educated about honeymoon phase, because very often we see that when you initiate insulin therapy, over a period of 1 month the insulin requirement goes down. There is some temporary recovery of the beta cells which may last for anywhere between few months to even a year, and during this phase the insulin requirement drops drastically. So what do patients and what do their families feel? कि हम तो ठीक हो गए. And this is where all the babas come into the picture, because they will go from one, they are going to go whatever you do, however much education you give, they are going to go and take second opinions, because it's a very big diagnosis. To live with the fact that your child has to take insulin for the rest of his life is something that is going to take time to accept. So this is the time when all those powders and uh, what that lakdi and whatever that you get is misunderstood. So what is happening is that naturally there is beta cell recovery and the insulin requirement goes down. A lot of kids go off insulin for a short period of time, and they attribute it to the alternative therapy, and all the credit is taken by the babas and whoever, and and you can lose the child because you've once accepted the diagnosis, then you've gone off insulin and you thought you were cured because of some miracle of God. And then again, you require insulin and then they never come back. Okay. And that can be life threatening. The child can lose their life. They can probably develop severe decay, land up in the hospital because they will not check. So that is the biggest problem, that when they go to these alternative doctors, they give them treatment, हाँ भाई ठीक हो जाएगा, and they tell them check करने का कोई जरूरत नहीं, आप देखो insulin बंद हो जाएगा. And that's what happens. So this is very very important, that at this first step, at this first consultation, you explain and educate them about honeymoon phase, that look, this is going to happen, this is expected, but you have to continue monitoring. A lot of times we continue a very small dose of basal insulin even if the child doesn't require it, just so that they continue taking the injection. You have to explain to them about insulin injection technique. We have to tell all the sites, because They'll go take opinions, and the site suddenly they start taking it on the calf. I've seen people take it on the forearm. So we have to tell what all sites. Nowadays there's a lot of awareness, but some people might just skip and uh, change the site to some odd places. And what is very important is they have to learn how to maintain the health of their insulin injection site. They have to take 4 injections for life, so they have to rotate their sites well. They don't have to take injection at the same place continuously, and they have to change their needles regularly so as to prevent something called as lipohypertrophy, which is accumulation of lipids at the site of insulin injection, which prevents absorption of insulin. So if the child develops lipohypertrophy, the insulin dose will go on increasing. There'll be a lot of fluctuations of blood sugar. So site rotation and teaching good site rotation from day one is very important. Monitoring. Now, this is not me. I'm not saying this from my pocket. These are the ISPAD guidelines. These are the ISPE guidelines. This is the ICMR guidelines, that every child with type 1 diabetes has to monitor 6 to 7 times a day for the rest of their life. There is no holiday. Okay, there is no hall pass, there is no detox. You have to monitor, means you have to monitor. And it is very important that all of us as healthcare professionals maintain the same language, because making them take the insulin is actually easier than making them monitor, and the treatment is incomplete without monitoring. So all of them, if we all keep saying the same thing, they will accept. Because what happens is they go to one doctor says 6 se 7 baar karna hai. They walk. We've seen patients get up and leave, that we are not going to do this. They go to another doctor, ha ek hi baar karo. They'll go to a third doctor who'll say mahine mein ek baar karo. So they are going to go keep looking for the answer that they want, but that is not the right answer. The right answer is that they have to monitor at least, if not 7 times, 4 to 5 times a day, every day. Okay, the concept now is to match insulin to food. Earlier, we used to match food to insulin. So, basic things like consistent maintaining the carbohydrate intake of every meal, and we can give them some basic education about carb exchanges. And at a later stage, once they are well equipped with everything, that is when carbohydrate counting comes in. So, we should not be in a hurry to start carbohydrate counting. Let them get used to all of these things. They will get a lot of variety even with using the concept of carbohydrate exchanges, and it actually works much better than carbohydrate counting, because when you teach them carbohydrate counting, they think they can eat anything. And it unfortunately is a very, I think it's a very abstract math, and it doesn't work as well as we think it should. Peer support, I think, at this stage is probably the most important, because it goes a very long way in helping them accept their diagnosis, because they have to spend a lifetime with the condition. We only have to spend 20 minutes with them, but they have to live with it day in and day out. So peer support is very important. If you know any local groups, or if you have other patients, you can just put them all in contact with each other. There's not much you need to do. They'll just do the rest. So all you need to do is just put them in touch with each other, and they'll just take it up, because they are also looking for some help. Okay, so peer support is very important. And what okay, my time's up. So the other thing is that the first month is when the insulin doses are very dynamic. So if you have educators, or if you have dietitians, or if you have resident doctors who are willing to take on the responsibility, what we often do is we make a WhatsApp group and let the patient be in touch with someone, at least the educator or the resident doctor. And that way, because there's a lot of change of doses that happens on a daily basis in the initial 1 month, till they settle down on a dose that is final for them. Because if they have to keep coming to the doctor, they are not going to keep coming. It's I mean, it's not possible to go every 3 days to a consultant. It's different when you're going to a general practitioner, but they are not going to go every 3 days to a consultant. Second is that they don't know at that time, what do I do when my sugar goes low, what do I do when my sugar goes high. So it gives a lot of help to have that backup support for the first 1 month or so. Thank you.
Thank you, Dr. Anushri, for a lovely talk. Moving to our next topic, I would like to call our next speaker, Dr. Kadan Natarajan. He's from Chennai. He'll be talking about the insulin during the renal replacement therapy.
Thank you, chairpersons, and also I'd like to thank Manoj and Purvi Chawla ji for giving the great opportunity. So we all know, dear friend, we all know that insulin is a main key player in the management of any form of diabetes at any stage, right from the end-stage liver disease or kidney disease, in the progress of these modern sciences. So these topics are somewhat complex because we are dealing with some of the patient with the unstable as well as the critically ill patient involving both hemodialysis, peritoneal dialysis, CRT, and so on and so forth. So the main contributing factor, pathophysiological factor of the progression of CKD to end stage is the diabetes, almost 60 percentage. The remaining 40 percentage will be hypertension. So these, our area is to concern regarding the management of diabetes because mitigating the complication of diabetes will be somewhat mitigating the progression of ESKD also. So it is a challenging thing, and also we ought to control the glycemia in this matter. And DM is the most common cause. So these both diabetes and CKD are both independent risk factors for the development of cardiovascular diseases. So controlling diabetes and also controlling the progression of CKD to end-stage kidney disease is paramount importance to prevent the complications of both macrovascular and microvascular complication. Kidney plays an important role in the glucose homeostasis because it has almost through the modification of both the glucose infiltration, glucose reabsorption, and part of gluconeogenesis and glucose utilization. So this makes an important almost 60 to 70%, and also the insulin altered metabolism also is important burden and things in the CKD progression. The contributing factor inflammation, oxidative stress, and physical inactivity, and so on, so for the including anemia and gut microbiota have the impact burden on the end stage organs like liver, adipose tissue, and also this skeletal muscle and pancreas. So the insulin clearance, you know that in end-stage kidney disease, the insulin clearance is somewhat reduced and also totally disordered. For any patient with the EGFR less than 14 to 30, 15 to 20, the administration of insulin, maybe in the premix or any other form of insulin, will have the impact of hypoglycemia and abnormal glycemic variability. So this is the need of the hub. We want to consider practice, especially in critical care patients, including the hemodialysis, the petrodialysis, to appropriate insulin therapy accordingly. CKD also induces insulin resistance because initially it was we are thinking about uremia and uremic shock and uremic sepsis also will be mitigating, will be provocating and precipitating for the insulin related uremia, but insulin plays an important role in mobilization of potassium also and also clearing of uremia among the critically ill patients. So what is renal replacement therapy is a medical therapy that replaces the normal kidney function in patient with acute or chronic kidney failure, especially in diabetes or hypertension patients with end stage, that is this was stage 4 or stage 5A and B. It involves the various techniques such as hemodialysis, that petrodialysis, kidney transplant already discussed by Jimmy, and also CRRT and hemofiltration. These are the main this one concept that we are implicating in renal replacement therapy. So diabetes management is very important. The changes in insulin metabolism and impact of dialysis glucose is very, very important. So high glucose content, because the peritoneal dialysis, they have the glucose-rich dialysate, and hemodialysis, they have the glucose-deficient dialysate. And therefore, if you go for the this one improper insulin algorithm, they will go for abnormal glucose, this one hyperglycemia, hypoglycemia, and all the increase this glycemic variability and complication also. Various guidelines have been implicated, but AAC and AD and our own RSS here clearly alluding that the important the clinician should follow the individualization. So the patient with the CKD rise from the stage 0 or stage 1, but we are focusing here in this renal replacement therapy stage 4 or stage 5 and A and B. So if any patient having the diabetes with end stage kidney disease, maintain the HbA1c between somewhere around 7.5 or 8 somewhere. So to prevent the complication, including the hypoglycemia. That too, elderly patients very, very important because elderly patients are almost frail and frailty, and therefore they will go for hypoglycemia and falls and fractures also will happen. So we know that hyperkalemia is one of the challenging burden among the ESKD patients among the diabetes because these hyperkalemia were contributing for the cardiovascular burden. So insulin infusions will mobilize the this one potassium to the cells and thereby reduces hyperkalemia. Also, there are some theory over that hypothesis on calcitrol also. Calcitrol deficiency, hyperparathyroidism, pseudo hyperparathyroidism also plays an important role in the insulin resistance and also propagating for the complication in the end stage kidney disease, the diabetes. So what is the value of insulin? CKD causes insulin clearance. This one demanding the reduce insulin clearance, and also there will be high insulin resistance, and that will be leading to the impaired glucose homeostasis. The contributing factor is propagated by the inflammation, vitamin D deficiency, anemia, and so on and so forth. So our area to advance the progression of CKD and also reduce the hyperglycemia in these patients especially. So insulin therapy is the only regimen that we have to follow. Even there are a lot of regimens, OADs are there, but there are certain limitations because even though this one, the multiple therapeutic options is or not there in the treatment of ESKD with the diabetes. Therefore, insulin is very, very important in clinical practice. Once the EGFR is falls less than 10 millimeter, 10 ml, insulin recommends also falls by 50%. So before the dialysis, on dialysis, and post dialysis, we want to configure the patient, and also we want to initiate the insulin regimen accordingly. Especially the basal bolus regimen is very, very important regimen that we have to follow in all the periods. So very fascinating slide, the insulin pharmacokinetics in CKD. We have multiple regimens. We have basal regimen, we have bolus regimen, we have basal bolus regimen, and some patients may use this one premix also. But the important regimen we have to follow is basal and bolus. Even we can use a NPH, but NPH which has spikes, and therefore it is used precaution, and we want to prevent the hypoglycemia. There are evidences with the glycine 100 also, and also evidences with the glycine 300 that is really European. They compare the head-to-head comparison with the Degludec as well as the glycine 300. They found that there was good glycemic control, but regarding with the hypoglycemia challenge, there is challenge with the glycine 300. For the insulin Degludec, there are no any dose alteration because it has a unique insulin protection that we already know about the soluble depot from the subcutaneous tissue with slow release, and thereby there are no any impact on the renal metabolism. Therefore, we can use safely with the Degludec, and also there are n number of studies with this Degludec injection, and this one renal impairment, including the ESRD. And also there are real world studies with the Degludec in the comparing with the glycine 300 both in type 1 and type 2 diabetic patients also. So bolus regimen, very good regimen, but regarding with the regular insulin, there are this one prolonged half-life in patients with reduced glomerular filtration rate, and therefore the risk of hypoglycemia is one of the concern. And we can use boldly this one lispro, aspartaglucin. It is unaffected by the EGFR, even in stage of 4 and 5 of CKD, providing a this one specific predictably safety profile that we can use in a clinical practice. Insulin pump, you know that CS2 insulin pump is very, very useful, and also we have automated insulin delivery by means of closed loop. This can be applied in peritoneal dialysis, because peritoneal dialysis we have two types. We have this one the continuous automated peritoneal dialysis and also automatic peritoneal dialysis. They can be fixed at the home itself, and they can either monitor by means of CGM, and it's very easy for them to follow the peritoneal dialysis rather than the hemodialysis. This is a basic algorithm we want to follow. That any diabetic patient on dialysis, that's before the dialysis, already under on OHA, we can continue if there are any hypoglycemia. But if there are any hypoglycemia, means please stop the OHA and go for the basal insulin accordingly, maybe Degludec or Detimel, Livimel like that, or any glycine 100 also. So we want to categorize that the HbA1c we have to follow between 7 to 7.5 or 7.5 to 8 or less than 8 like that. Insulin on before the dialysis, because any patient posting for hemodialysis or peritoneal dialysis before the dialysis, that is premix insulin, they are already under arm, reduce the morning dose by 50%, because most of the hemodialysis they will be performing the unit by only the morning. And the basal insulin means we go for the reduction of doses by 40 to 50% in the morning, and the night means you can reduce the doses by 30 to 40%. So the patient already under an MDI, that is a multiple delivery dosage, means you can go for basal one side and also bolus one side. On bolus we want to reduce by 50% both in the morning as well as in the evening. This is very important slide, my dear friend. This is the insulin regimen on the dialysis days, because the insulin clearance have been enhanced, and therefore the glucose clearance also have been enhanced. And therefore, if the patient already on rapid acting insulin, we want to reduce the insulin dosage by 10 to 15%. So any premix or a biphasic insulin, once again, they want to reduce the insulin by 10 to 15% accordingly in the morning or in the afternoon or in the evening. But in long-acting insulin, that's reduce the dosage by 25%. So before the dialysis, 50%, and during the dialysis, maybe around 20 to 20% will be applicable. This is very important data regarding the dosage adjustment of insulin. On comparing with this the placebo, they found out dosage adjustment is very, very important in clinical practice, especially in going for hemodialysis. And this data show there is if there is adjusted and non-adjusted dosage. In non-adjusted dosage patient, that is on the dialysis time, by 25%, there is increase in hypoglycemia has occurred, and comparing with this placebo, and therefore there is non-adjusted insulin group produce a significant increase in heart rate also, because most of the CKD patients, that the end-stage CKD patient, will have this autonomic neuropathy. They have the burden of cardiac autonomic neuropathy also, and this will inculcate for the any cardiovascular diseases burden. This will dead bed syndrome or any atrial fibrillation like that. So therefore, we want to propagate, mitigate the heart rate among the ESKD patients. Once again, in peritoneal dialysis, there are multiple regimens, but we have to individualize patient, which patient need which type of therapy, time and doses that we want to regularize. Once daily insulin, we have basal insulin, glargine, we have detimer, we have declotec, we have pre-meal short acting. Also, we can use like aspart and lispro, glulisine in peritoneal dialysis is very important. A message we want to write, because Bosal and Bolus and Basal and Bolus only plays an important role. Consider zero point 0.5 units per kilogram as starting dose, with the 50% of the dosage on basal insulin and 50% of dose as the prandial insulin. For those who couldn't able to use the multiple daily injection, means consider the premix, low premix, or high premix accordingly, especially for the PD patients, that is peritoneal dialysis, special exchange with the continuous peritoneal dialysis or intermittently peritoneal dialysis also. Once again, CRR, that is nothing but the continuous replacement of renal therapy before blood glucose. If you see the blood glucose is before the CRT will be high, and during the CRT once again will be less, and hypoglycemia progression also will be more, and therefore we have to maintain the insulin dosage, regular insulin doses, adjust the insulin doses, and after the CRT once again the blood glucose will rise. Blood insulin need, the insulin clearance will be high, will be reduced before the CRT, and while during that CRT will be enhanced, and therefore the hypoglycemia risk, and we have to adjust the dosage. We want to monitor it properly. And the insulin dosage recommended also will be less before during the CRT regimen, the dialysis therapy, and therefore we have to monitor them carefully. We want to this one prevent the hypoglycemia in these patients. So, my definition in summary, RR, that is renal replacement therapy, is primarily indicated for ARF, CRF, and that is in ESKD patient, and is also used to address the electrolyte imbalances, acid-base abnormalities, toxin removal, and fluid overload, especially with by doing with the hemodialysis, peritoneal dialysis, as well as the hemofiltration by means of CRRT. Chronic kidney disease require low insulin doses due to decreased clearance. Reduce the insulin administration by 20% for type 2 diabetic patients undergoing hemodialysis or dialysis days. Maintain the glycemic control and result in fewer hypoglycemic agents, and also regularize in potassium, because hyperkalemia is one of the important challenge among the this one of CKD patient with end stage, and also insulin infusions will be very very helpful to mobilize the potassium to the this one peripheral tissues. That will be helpful to prevent the hyperkalemia. We can maintain that one. Calcium also plays an important role in preventing this abnormal glucose regulations, and also glucose and enhance the insulin metabolism also. So insulin levels were high before the CRT, and also decreased progressively during the treatment. The important key message that we want to learn from this topic is the management of diabetic patients or maintenance dialysis is a real challenge and require a multidisciplinary approach, especially by diabetology, renal, and endocrinology. Ideally, therapy should be individualized for each dialysis patient to reduce the diabetic complex, especially hypoglycemia or hyperglycemia, to prevent the abnormal glycemic variability. Recently, we know that kidney transplantation along with the pancreatic transplant also may be helpful in the premier replacement therapies. The diabetic patient, with especially with the end-stage kidney disease, with the EGF are less than 15 or less than 10, because it enhances the patient quality of life, as well as the prevent the complication also. Thank you very much.
Thank you, Dr. Kannan. For the question answers, we'll take it later on. I'd like to call us our next speaker, Dr. Mayuri Kale. She's a consultant from Aurangabad. She's going to talk on insulin during pregnancy.
So good morning. Thank you, Dr. Manoj and Purvi, for the invitation. Thank you, Chandani and Chairperson. Sorry. So my talk is insulin in pregnancy. So if you say about pregnancy, what should be the treatment? Since we know that most of the diabetes in pregnancy will be gestational diabetes. Almost 90% diabetes is gestational diabetes when you talk about pure pregnancy. There is diabetes which is previous to pregnancy, that is pre-gestational type 1 diabetes, pre-gestational type 2 diabetes, or any other type of diabetes having before pregnancy. There is one entity called as early gestational diabetes. What was seen previously as 24 to 20 weeks when there is a pregnant diabetes, it's called as diabetes in pregnancy, or GDM it is called as. And prior to that, now 8 to 10 weeks, 12 weeks, we are getting patients with diabetes. So whenever the placenta starts working, that time only we are getting diabetes in these patients, and this is called as early GDM. So there are distinct entities where we will need insulin. Pre-gestational, any diabetes patient should be on insulin. Early gestational diabetes, I it is always preferred to give insulin only. Late GDM, the pure classical GDM, where we may have option of choosing from the diet, medical nutrition therapy, and maybe oral drugs. But overall, insulin is one of the safest drugs. So here we see the statistics. The hyperglycemia in pregnancy, the global prevalence is almost 18%, and proportion of cases due to GDM will be 80%, but rest of the cases will be either pre-gestational diabetes or detected just during pregnancy. So this is, you can see hyperglycemia in pregnancy in the Southeast Asia region, it's very high percentage, and 1 in 6 live births occur to women with some kind of hyperglycemia. We know, we said that GDM is the mother of all non-communicable diseases, so we need to treat it aggressively. So here also you can see all the complications occurring because of that. The fetal insulin resistance syndrome also, I think this is covered previously. So the primary treatment goal in pregnancy is complicated by diabetes is to prevent the cycle from starting, and it can be accomplished by achieving and maintaining as normal as maternal glycemia as feasible, and preferably beginning, preferably means we have to, there is no other option, so we have to start. I usually start at least 3 to 6 months prior of the prior to planning pregnancy. So there are benefits of treatment, that is insulin doesn't cross placenta, and the reducing risk to the fetus compared to the oral anti-diabetic drugs. It helps to maintain optimal blood glucose level. Obviously, we cannot titrate the oral drugs, so insulin is the only drug which can be up titrated or down titrated as according to the needs of the patient. What are the indications which I discussed just now? So insulin requirement, what happens to the insulin requirement during pregnancy? There is variability in the insulin requirement, especially during the first and third trimester. Here you can see very well that if initial, you can consider as 100%. So first 12 weeks to up to 12 weeks, there is increased insulin sensitivity in the mother, so there is decreased insulin requirement by almost 20%. But as the pregnancy progresses, there is increased insulin resistance, especially when the human placental lactogen, the cortisol, the growth hormone, they start acting, and that time there is increased requirement of the insulin. We have seen that probably at third trimester, maybe at the start of third trimester, there is high requirement, but eighth, 9 month, maybe it may get plateaued sometimes in many patients. So it may not necessarily go up as shown in the this graph. When to initiate insulin? So whenever the fast, this is mainly of GDM or early GDM, you can consider. Pre-gestational, we have to start insulin before planning pregnancy. So here you can see on an average, whenever the fasting blood glucose or pre-meal, any pre-meal also, more than 90 to 95, 1 hour more than 140, and 2 hours more than 120. So this I think we need to fix it in our mind, and whenever it is going up, we have to start insulin. Because I see a lot of resistance from the patients as well as sometimes from the gynecologist also. Why do you want to treat with insulin? But we have to be very clear, and we have to tell them very clearly that the treatment is not for the mother, but it's for the baby, so that the baby is healthy. And I'm getting all kind of resistance from everyone, but still I'm steadfastly telling them that we have to, we lose patience also many a times. They do not come back to me many a time, but still I think we should never leave what is really, as Anushri said in her previous talk, that we have to be like that only, and we have to be maybe consistent in telling to the patients. So, fasting and postprandial hyperglycemia, we will use basal bolus, and only prandial hyperglycemia, we will bolus insulin. So but still, this is the, like, I would say this is a scientific sentence, that no conclusive evidence for the threshold value at which clinicians should start medical therapy, because many a times, even if the blood glucose levels are controlled, we see macrosomia in many patients, in the baby. So there we may target little lower, so we may target the postprandial as 110 milligram, and the fasting between absolutely between 80 to 90. Here, even if the patient is having 120 or 130 post meal and fasting of 95 to 100, I may start insulin. So lower threshold might be there, but it is still the clinician will decide about it. These are the glycemic targets. You can use CGM in pregnancy, but my personal experience has been not really very good with CGM, because what happens, the pregnant women are so conscious, they don't eat. They keep on scanning, and if whatever is going to increase the blood sugar, they don't eat. They may not eat anything, and I have seen many a times, in a couple of cases I have seen that the baby weight is not increasing because of that. So I am not really using lot of CGM in pregnancy, but yes, in type 1, it is very useful. Obviously, we don't have a lot of type 1 with pregnancy. So these are the target blood glucose levels. During night, it is very important to prevent hypoglycemia. The blood glucose should be more than 60. These are the few insulin like basal, premix, prandial, basal bolus. Only co-formulations are not approved in the pregnancy. We are using regularly glargine, NPH. NPH is safe and Retimer is safe, categorized as. Glargine and degludec is to weigh the risk benefit ratio, but I think most of us are using glargine U100 as well as glargine U300 in pregnancy. And recently we have started degludec also, because we have a trial in type 1 diabetes where it was started pre-pregnancy and it was continued throughout the pregnancy, but and it showed almost similar outcomes. Obviously we'll need more data, but it seems to be safer, so we can use it. Premixed also we can use it, but I am not using it very regularly. I feel basal bolus is the only standard therapy in these patients, because the titration which is required in this group is very different. We will come to the titration again. And yeah, so which basal, whenever the fasting blood glucose is has, I said detimir, you glargine 300, you degludec glargine 100, any can be used. So I think I've covered this. Coming to the prandial insulin, which one would you use? We are using regularly actrapid, that is the human regular insulin. We are using aspart also, sometimes lispro. Glulicin, we do not have any data, but the fast acting aspart is my favorite, so that is why I've highlighted that. And I'm using it very frequently with very good results. The action begins faster, peak is higher, and it disappears faster also. It reduces basically nocturnal hypo, because when we are, what we are seeing very commonly, I think all of you must have noted that the post dinner blood glucose in this group is very high usually. And whenever we are giving high dose of the bolus at that time, the patient lands up in hypo late night. So here I found the faster acting aspart is doing very well. And we are giving basal insulin also at that time, so the action, both the action may come together, and there may be hypo. In this situation I find the faster acting aspart is faring better. So this is the categories of FDA categories of these insulins. There is the recent systematic Cochrane review has was not able to recommend any specific insulin regimen over the another, but as we said, basal bolus is the gold standard and we should use. And in pure GDM, maybe only bolus insulin can be used. Insulin pumps, yes, can be used in pregnancy. What are the recommendations for pre-existing type 1 type 2? As I said, we have to continue with basal bolus, and we have to give extra insulin maybe whenever corticosteroid is being given to the patient. We see very commonly 1 or 2 weeks prior the steroids are given, and we have to titrate insulin according at that time. What is the dose usually pre-gestational? This is approximate dose. So zero point 0.7 per kg per unit, zero point 0.7 units per kg per day for first 12 weeks, then later on point 0.8, point 0.9, and during delivery, just prior to delivery, maybe 1 units per kg per day is required. Initially, there is less insulin required in the first trimester, and it goes on increasing. So how would you divide it? So we the common thing what we do is 50% as basal at bedtime, and 50% divided into 3 doses or two doses depending upon the number of meals patient is taking. But still I feel we need to monitor every 3 to 4 days. Maybe if we are giving glargine, you can monitor after 3 days or so. So if you start with glargine, if you start with degludac and u300, maybe we'll wait for 5 days, and then we will see the pre meals and 2 hours post meal, and we will keep on titrating. As Anushri said, in type 1, almost in the similar way, I would advise to monitor in patients with in hyperglycemia and pregnancy. Maybe every 2 or 3 days we should monitor at least. So every day, if patient is doing nothing like that, but every 2 to 3 days it will give maybe the action of insulin, and the carryover effect of the previous dose change will be seen, and we can do that way then. In patients who are having GDM, as we said, same, maybe Lispro or Aspart are sufficient, but as required, we can give basal. So 90% of the GDM patients are able to achieve targets with lifestyle modification, that is diet only. During labor and postpartum, so this is one slide I would like to add here over here. So if the patient is 60, blood glucose is less, we can continue with 5% DNS. If 90 to 120, which is the target between delivery, for the delivery we may not give anything, and rest of the 120 to 140 we can keep, and on adding the regular insulin we can use aspart, we can IV also. So what my practice is common is usually, if most of the patients who are having on high insulin they go for cesarean, and I advise the gynecologist to take the patient early in the morning. Since the patient is very well controlled, I need not give anything in the morning, and cesarean takes not more than 30 minutes usually. As you induce, the fasting is controlled, and you induce the patient and take the cesarean, within 30 minutes the baby is out. Once baby is out, we are little relaxed, and maybe postpartum the insulin requirement is reduced by almost 30 to 40%, and you can give titrate and accordingly. Only thing is to have very good control during that hour of delivery, during that 1 or 2 hours, or maybe when the patient is fully dilated, at that time we need to have, for previous 1 or 2 hours, we need to have the blood glucose of 90 to 120, and we can titrate it accordingly. Or alternatively, if you don't want to use 500 ml, you can use 100 ml and put the insulin. Maybe if you put 10 units in 100 ml, the 10 ml will give you 1 unit. So accordingly also you can titrate, so that there is no wastage of the pills. Immediately postpartum it is reduced, and we have to monitor, and accordingly we have to give the insulin. So what are the risks and consideration? We have to think about the hypoglycemia, and managing the hypoglycemic episodes, giving injection, educating the patient is very important. This is one network plot analysis showing the comparison of all the strategies used for the GDM treatment strategies. So B, you can see B is the insulin. This is the, this is comparison between these bars are the comparison. The more thicker the graph, the more studies are there. The more bigger the circle is, the more number of patients are there. So here you can see more number of patients in the insulin group, and this is comparison with metformin. This is the most commonly done, followed by glyburide and the rest of the therapies, diet and exercise. So here what was found is that unfortunately there is little higher incidence of NICU admissions, and higher incidence of neonatal hypoglycemia in the insulin group. But still, for my practical purpose, I will not agree with this, though this is a network meta-analysis. And compared to maternal outcome, there was increased incidence of cesarean section, but preeclampsia was lower in the insulin and metformin group. To summarize, insulin is the only effective and primary therapy for hyperglycemia in pregnancy, especially those with pre-gestational diabetes. Classic GDM, we can use regular or short-acting insulin. Other, basal bolus is the therapy. Titration and monitoring is must. And insulin is the only safe therapy for mother and fetus. So thank you very much. I invite you for the pregnancy study group meeting which will be happening on 30th November and 1st December at Chhatrapati Sambhajinagar. So please do register. Thank you very much.
Thank you, ma'am. It was really an amazing lecture. I would like to call all the speakers, Dr. Jimit, Dr. Vipul, Dr. Anushri, Dr. Kanan. Ma'am is already here. We don't have much of a time, but one, two questions we can take from the audience if somebody has to ask something. Any questions?
Ma'am, to ask you, in an 11-year-old, you would never use a pre-mixed insulin for type 1. I missed your lecture in
So
between.
no premix, only basal
It's only
bolus.
basal. But once
Only
they are
basal.
well controlled,
No premix, never.
what is the reason?
Um, so in a person with type 1 diabetes, there is absolute deficiency of insulin. And in a premix, you cannot titrate the insulin doses to the requirement of the child's to the carb intake that the child is taking. So nowadays, what we do is that whatever carb intake the child is taking, according to that, the dose is adjusted.
But when
And
they are going to school, because they're generally in the 6th, 7th standard, or if I remember, I mean, in that age group. So, I mean, pediatricians have been giving it.
so a lot of the times, the pediatrician do give a small dose of premix. That is a different situation. They give it in the morning
Morning,
so that it covers the afternoon, break snack in the break time, that is in the school. If the regular insulin doesn't work well, or if there is no provision in the school for the child to take an extra injection because the child is not yet independent enough to take it on their own, and in metros especially, the school is too far, and the both the parents, so it's a very specific situation. And but as a rule, no, but it's a very specific situation.
May I add to that? Just, ma'am, no premix at all advised anywhere, no matter what. Even if you need to give a, dose which is short acting and long acting, you can split it. You can use regular and NPH if it is to save money because of the right dose being given. And school insulins are absolutely allowed. It's also part of the school GR now by the government. No child can be denied insulin in the school, whether it's a Zilla Parishad school or a extremely fancy public school. So it's best to do that. Yes, and it's extremely physiological, as Anushri said. So we want to give them physiological therapy. What you said was that child is well controlled. They seem well controlled. If you do a CGMS, you will find lots of highs and lows, and that is not visible in a normal SMBG. So it is not physiological and not good for the child.
So I already mentioned in my presentation, but I would again insist that insulinization for India is very, very important. We are living in a tsunami of type 2 diabetes. We are seeing diabetes in teenage, 20s, 30s, and we are developing complication a decade earlier than our Western counterpart. So we have to be very proactive. We have to be very clear that insulinization, whenever required, we will start insulin, whether it will take our 10 minutes, 15 minutes, or 20 minutes. But the time you spend will save patient's organ in the end. And that would be the biggest incentive for a clinician to spend time with the patient. So insulinization for India is a need of an hour. And let's we all unite, as Dr. Anusri already said, that we all have to be on same page. We have not to offer patient के एक डॉक्टर ने बोला इंसुलिनलाइजेशन करना है, चलेगा ये ट्रीटमेंट से ये कर दो वो कर दो. That is not be to be done by us. We have to start insulin whenever it is required, and we have to decide that we will start that insulin. Thank you.
May I ask a question?
Yeah, please, ma'am.
Any experience with all the speakers with generic insulin? Because there are lots of misconceptions yet that it is not safe. So where the cold chain is maintained, I think that was one concern. But other than that, because a lot of people are using, it's half the price. If you're using glargine in generic shops, it's half the price. All insulins are half the price. So it makes basal bolus affordable, whether it's for a pregnant woman or for so any experience, any thoughts, any knowledge,
So
Mayur,
yes,
please.
we have to use generic insulin in India. We have to uh, whether if the treatment is scientific, we can go for generic. And the beauty of treatment with insulin is that we are continuously monitoring. If we start with the generic tablet and other standard tablet, it will be a different story. But in insulin, whenever we put patient on insulin, we say at least monitor one sugar per day. So if generic is not effective either because of DRS and cold chain or because of the substandard quality, we will have hyperglycemia and we will definitely come to know. We can educate the patient, either we will change the insulin or we will up titrate the dose and we will get the desired result. About safety, if anyone has different opinion.
Would you be comfortable using in a
No, no, not absolute, not really. That's true. Yeah.
still, are you comfortable?
No, no, I'm not at all comfortable. Basically, I'm not using also. Even in type 1, it's whenever I don't have option, then only I'm going for generic. Especially, I'm asking, there are a lot of generics also. If you talk about some standard generics, then it's okay. But the very cheap generics, I'm really telling whatever the patient thinks, I don't care, but I'm not advising them. And I'm seeing that the like most many a times the control is not there, or even if the control is there, there is little bit 10% or sometimes 20% increased insulin requirement is there. So at least some standard generics may be acceptable, but the not very cheap, I'm not accepting. It's up to
There
it.
is only one. Across the country, there's only one type.
Yeah, you're talking about, I mean,
Only insulin.
insulin.
There's only one brand. There are not many options.
You're talking about analogs or your routine use,
Analogs.
but
Analogs.
still I'm not using using it.
Exactly. That's why I said most doctors are not comfortable. And I just wanted to raise a point.
In Chennai, we have a unique trust in the name of Kanika Parameswari. So on behalf of our colleagues and also along with our leader, Dr. GVK sir, we are giving every week, giving insulins, free insulin for type 1 diabetic patients, especially both basal as well as bolus. Bolus, they are giving, basal, we are giving NPH, and bolus also we are giving actrapid form for the need patients. So couldn't be able to go for the on this one government setup, we are doing on behalf of GVK sir. And also for all type 2 diabetic patients also we are giving free of cost of insulin. Almost every week we are seeing around 300 to 400 patients. Among that, 20 to 30 patients, they are eligible to get the insulin. Is free of cost we are giving.
True, sir, but ultimately we have to empower people to be able to buy it themselves. I mean, all of us are doing that work, and this is great that what you're doing. But if they can buy and afford it, ultimately we need affordable insulins, whether it's for pregnant women or
Yes.
type 1 or type 2. And that's why I was raising that point of generic. And I agree with Mayura that sometimes it's very difficult to build the confidence to be able to use generic. And if it was possible, it would be great if we had some study of generics. I think this is an open thought to all the young people here. There could be a study of generic glargine versus that, and if the study came out well, it would give us confidence to use it. That's
Yes,
just
ma'am,
a
in
thought.
my city in Surat, what I have seen, there is a government hospital, main government hospital, a civil hospital. The patient who are not affecting type 1, they go there. Usually they find it adequately controlled because of the cold chain is maintained at the tertiary care hospital. But whenever they go to generic store, I've seen most of the patients, they find no derangement in the glycemic control. So most of them where the issue is there accordingly, they'll end up in the vials. So vials for the glargine also and vials for the regular humans, they are very, very cheap, and ultimately they use that. And the difference is seen mainly due to cold chain, I think.
So there are multiple layers of generic versus standard, and whenever we are getting good glycemic control, I think our target should be there.
Thank you.
I'd like to call the speaker here to give it to the memento. Dr. Anushri. Dr. Jimit, you give it a memento here.
Dr. Suresh Purohit from Mumbai.
वो पहले चेयरपर्सन को बुलाओ दूसरा ठीक है एक सर को
Okay, good morning, everyone. And first of all, I would like to thank Manoj and Purvi for inviting me for this wonderful conference. And I will invite my co-chair, Dr. Vinay and Dr. Sarda. Please come and join me here. And we will be talking about the insulin pump and various aspects of the insulin pump therapy and the current scenario. So I will ask Dr. Archana to um, set the ball rolling.
Yes. So I think we have no chairpersons, moderators, speakers. All three of us will sort of have a good session on the pump. There are few people here, so I think let's include you in the discussion. And all the people in the hall, any of you have used a pump? Is anyone here who has used a pump? Have you seen someone use a pump? Have you seen a pump
in my residency I have removed one pump
removed?
and put them on basal volume during admission.
Acha, during admission.
Very good.
Okay.
That is also very important. If the
That's
patient
important.
comes to a hospital and having some complication,
Hmm.
so it's better to remove the
Rem-
insulin pump because every hospital does not have pump trained doctors to handle them. Actually, it is not required, but even if you do it, it's very good. So you are not in dilemma whether pump is working, not working, and whenever you give sub-Q doses, you are sure the insulin is going. The purpose of pump is only to deliver insulin. So when you remove the pump, it has happened with one of my patient in Beach Candy Hospital also. He was admitted there and they removed the pump. And that time I thought, oh, why did they do that? But it is all right because now they are going to manage. So inside the hospital, whomsoever is managing, allow him to remove the pump and let him manage on sub-Q doses. And once the patient is with pump specialist, they can always put the patient on pump. So that's a good thing. Thank you.
So that's very important, and we'll talk about that. Yes, pump. Yes. Hmm. Know how to do that. Okay. Anyone there? Anything you know about a pump? Have you seen a pump? Any concept that you have? What does a pump do?
We can get some supplies here.
Everyone come here, please. Aage aaje. See, we are very few people. We can just have an intro. There's no point giving a whole lecture
Uh,
if it doesn't suit your needs. So, any concept?
yeah, yeah,
Have you been
be
using a pump, sir?
interactive and talk in between. Huh?
Are you
Don't worry, it's a
using a pump?
very informal session.
It's
Okay, nobody
absolutely
is judging
informal.
anyone. It's all right if you
I
don't
mean, for
know.
example, I have 1,200 kids with type 1 diabetes, and I'm not a great pump user because of low cost setting that I live in. But I believe in that, and I have only 10 children who are currently on a pump. So, out of 1,200, considering that it's a very small percentage, but being aware knowing what it can do when we can afford it, it's very important. So I think I'll just set the context by saying that one thing we all know, an insulin pump is used for insulin delivery, right? So most people perceive, and this is a myth, that the only purpose of a pump is to have less number of injections. So I think next 5 minutes I'm setting the ball rolling by saying, what more does a pump do? See, it's very simple to put up a slide. I think we can do without it right now. And when you go to the details, we'll do that. It's very simple. Say a person takes basal bolus, that is 4 to 5 pricks in a day. And when a person is on a pump, it is 1 prick in 3 days. Right. So the dramatic change of number of pricks is what motivates most people who can afford it. "Ki, let's put my child on a pump, it will be less number of pricks. But across the country, we have met so many people, and this used to happen before the 780G pump came. I mean, after 780G, and we will tell you, doctor will tell you more about it because he knows and he's been using it. After 780G, the scenario has changed. But before that, in spite of being on a pump, I have money, I spend 4 lakh rupees, I put a pump, but I have no clue what to do. So just saving number of pricks, and HbA1c is still 9, it's still 10,
9.5.
right? I mean, what's the point of having a pump if it's just to save pricks? So number of pricks being less is just one small advantage. It is not the main purpose.
Yeah,
So
but
now I would
again,
like to
yeah. So
ask, is
again,
anyone else
yeah,
can say what
I
could be
will
the
continue
purpose?
on that.
Hmm.
And again, the number of pricks in a child, he's surrounded by so many people, family, other people. So for them, 4 injections, patient comes and tell me, doctor, my son is or daughter is taking 4 injection. Can you make it one? Can you stop diabetes completely? So their injection is very big concern for them.
It's
But
important.
for us, it gives a minor improvement. But this is how they get into the system. First, the injection will be less. Otherwise, it will be 1,444 odd injection.
It's a
And
great
yeah,
motivator.
so one is that. And second thing, once, because now the game is totally different. Anyone can put anybody on pump. It's not a big deal because now you have a CGM, which is very cheap. It gives you 14 days or 7 days data all the time. So you are not at risk at all. Every time you can check your blood sugar. Earlier it was like that every time you have to make a prick. So 7 pricks a day, it is crazy. The whole family is doing one job only to check the child's blood sugar and give the injection and boluses and carbohydrate. But now the pump has improved a lot, and there is a AI based, and also things are very simple and easy, and it is very much convenient. Like he can also put in some. Now patient even don't call me. Once I put them on pump, then they are on their own. They just, on my request, they send a data ki my HbA1c is 6.5. Very good. And earlier when I started, there was a 508 pump. Then the paradigm came. There's so many, more than 2000 patient on pump, and it was always a problem for me because they all come with the blood sugar of the or HbA1c of 8 or 9. So sometimes we don't know if we are wrong or patient is wrong or insulin is not working and all. So now the scene is completely changed.
So, before Dr. Vinay will take you through the presentation on how the pump works, I want to again speak to you for a minute about the clinical aspect of it. So, what do we want for our patient with type 1 diabetes? A person living with type 1 diabetes, whether it's a 1 year old baby or a 30, 40, 50-year old. Ultimately, we want physiological insulin replacement. So, as near physiological as possible. All of you must have seen, like, for example, the dawn phenomena. It's such a difficult thing to tackle because we don't know what to do. So when we give basal bolus, which is a standard treatment today, and often we are able to achieve a very good HbA1c of 6.5 or 7, even with basal bolus. And as Sir said, if you have CGMS and basal bolus or SMBG and basal bolus, you may achieve it. And you can, we do. But if you put the same person, what is the difference? Here your basal rate is fixed. I just want you to understand, why would you want to use a pump beyond saving pricks? In a pump, you can do much more than just deliver insulin. You can have a variable basal rate. Suppose you gave Glargine 20 units or 10 units at night. You would not be able to change the rate when the person was exercising or gymming, or early morning increase is there and you would need more basal in the morning for the dawn phenomena. All these things, or a small spurt. How many times would you give a child who is grazing? You know, a small child is going to eat every 2 hours. Had food, again hungry. Had food. How many times are we going to prick that child? Right. So ultimately, we give a compromised, non physiological insulin replacement. And that is the beauty of a pump. And it has so many more features on how that bolus can be delivered. It's not even just one fixed bolus. If you have a fatty meal, if you have a high protein meal, it can be spread over time. So, all those things, Dr. Vinay is going to take us through what a pump actually does. So, in next few minutes, I think over to you. If you could tell us more about the pump, and then clinically we will discuss at the end of it.
Yeah. So can I have my slide? Yeah. So very interesting. I would like to thank Dr. Chawla sir for a very interesting topic. It was onboarding and flight. So I was thinking. So I put this picture of cockpit. So as a doctor nowadays, you will be divided into only two categories: the doctor who uses technology and doctor who doesn't use technology. And when you're using technology, we don't learn technology from the books. We use learn technology from using it. So did you take any WhatsApp classes or no? My mother is better WhatsApp user than me because I never use WhatsApp, so I thought that it is too much privacy. But then okay, she knows more than me in terms of WhatsApp. So it is about technology. If you use it, you feel it, you touch it, you will learn it. So when we are looking at insulin pump therapy, it is, as ma'am has very beautifully mentioned, that the what is the goal? As a doctor, when you're giving insulin, insulin is a very dangerous hormone. If you give more dose, it can cause hypo. If you give less dose, it can cause hyper. So it's just like a running a flight. So that is where, as a doctor, and if you have a diabetes educator at home, you both are running the show. Just like here you can see in the picture, you both are running the show and you both will help them, people with diabetes, to achieve the objective, that is get as low as possible with safety. That's what the so yeah. So when you're looking in India, what are the different types of pumping insulin devices that are available? When you look at it, there are three different types. So you can use, if you're on the left hand side, it is just a pump. The objective is just to give the insulin. As a doctor, you can set the basal rates, you can tell the patient how to take bolus insulin and all. That's it. Then if you look at in the middle, there is an insulin pump that is with CGM. I call it dumb pump because it doesn't take any action. So if you look at our body as well, we take glucose sensor data and then they decide that how much insulin to give by beta cells and all. So similarly here in this pump in the middle, it will show you what is the sugar, and then you have to set accordingly insulin how much to take and all. But the third one, which has revolutionized type 1 diabetes, and that is called, we call it automated insulin use. If you read standards of care by ADA, ISPAD guidelines, ACE and everything, it says automated insulin delivery. And in this, what happens is that based on the sensor glucose, every 5 minutes the basal rate is changed. So imagine, as a doctor, how much time you can give to your patient with type 1 diabetes. Maybe an hour or 2 hours in an entire year. If he comes to you more than 2 times 3 times, so maybe 3 4 hours, but he has to manage his life every day. So that is where this, as an automated insulin delivery, it can change the insulin delivery every 5 minutes. And that is the fantastic way, because if you see, the variability in the glucose is a norm in type 1 diabetes, and even if it's somebody on type 2 diabetes at the fag end of the disease. So that is what this thing does. So uh, in the with the earlier pumps, the biggest challenge was that as a doctor, you were not knowing how are they doing. If somebody is far away from you, how are they doing, what are they doing? You were always worried in your mind, are they doing well, are they doing good, are they not doing good? So now, if you look, the insulin pump system has completely changed. It is a system. Now if you are sitting in your clinic, you can see how they are doing, because these pumps are connected to mobile phone. The data is constantly uploaded thanks to Geo and all. Now the data is so cheaper, everybody is on mobile phone with internet, so that makes the life much easier for you as a clinician, that how they are doing. And now you can ask them to come to your clinic if you see that things are not going well. So if somebody's sugars are flying very high, you can ask them to come back and see as well. So that makes the life much easier. Ma'am, shall I take starting? Yeah. So, starting insulin pump, don't worry, it's very easy. It's not big deal, just 5 steps, nothing big. So when you look at the first step, is most of the people with diabetes in India, when they move to insulin pump, they are already on multiple daily injections. So first step is just simple. What is the total insulin that they are getting? You can just add the basal plus bolus, that becomes your. If you look at the second step, is that now this is King's College protocol. You can design your own protocol as well. So I'm just showing you one protocol that is there. So they look at A1C of the patient. If A1C is less than 8, they reduce the total daily dose by 20%. If A1C is more than 8, they don't reduce the dose. But if it is your first insulin pump, it is always safer to start by reducing the 20%. Then you can divide by 2 to get the basal dose, total daily basal dose. And then rest of the things you can calculate your ICR and ISF. But if this is your first pump, don't do it. You can use your manual boluses as well. That's fair enough to start with and all. Because when this is your first few pumps, I think it is better to be keep it as simple as possible. But if you optimize it, particularly in sorry, I'm not able to change this. Okay, now it's changing. Okay, fine. So when you are using it, so here if you see the the beauty of insulin pump, ma'am has said that you need variable basal rate. We don't have common one basal rate. If you are injecting a glargine or any other basal insulin, once it's injected, it's there. You can't remove it. The good part about the insulin pump is that you can change the basal rates. What if somebody goes for a play? What if somebody is uh, going to drink an alcohol and all these things? So all these cases you can actually increase or decrease the basal rates as well, and that is one of the important things about it. Yeah. Now, very interesting thing is that if you have a person with type 2 diabetes or in the early phases of your first few pumps of type 1 diabetes, you can start with single basal rate, get comfortable, and then you can change the multi. So this is very interesting protocol by King's College London. So they say that if you want to start the basal multiple basal rate from day one, how to do that? So they ask only 2 questions to the person with diabetes. The first question: when do you get up? So let's say in this case, if somebody is getting up at 7 o'clock, then 3 hours before that, they increase the basal rate by 20%. Why? To counter dawn phenomenon. And then from 12 o'clock in the midnight to that period, they reduce the basal insulin dose by 20%. Why? To avoid the nocturnal hypo. Then in the daytime, because we are active, we go around and all, they decrease the basal rate by 10%. And then after the dinner, they increase the basal rate by 10%. So 20, 20, 10, 10, simple rule, and you can get multiple basal rate from day one as well. Now you'll say, oh my God, is it something they come up with, is like a Bible or, holy book which says, this is what, why should I take it as a dictum? Let's look at the evidence. So they look at the basal insulin secretion of people. And this is like, if you look at 6 to 12 years old, if you see that the basal insulin that is being secreted, you can see there is a small hump during dawn time. And then in the afternoon time, you can see the basal insulin requirement goes down. Then again, after dinner, it will goes up. So you get very close to each other. If you look at little 12 to 18 years, and if you look at their basal insulin pattern, you can see that in the dawn time it becomes, the peak becomes more prominent, and then in the afternoon time it goes down. So if my 20 20 10 10 formula, I can get closer to the physiology. If you remember what ma'am said, our objective is to get as close to physiology as possible. If that is what we want, this is where you can get it accordingly. And if you look at the adult population, then the dawn hump becomes more prominent. You can see that the beautifully the basal insulin requirement goes very high during that time. Now if you're giving the glargine, NPH, other things, can you do it? Theoretical answer is yes. You have to inject it multiple times. Now will you inject basal insulin also multiple times? It become difficult. But with the pumps, you can set the basal rates and you can do it as well. Now the question is that if I want to change the basal rate, because if you calculate somebody's basal rate, does that mean it will continue? No. The If you calculate basal rate and if you see that the sugars are going high or low, then you can change the basal rate at will. But when you're changing the basal rate, it is going like 0.25 unit per hour. Imagine, it's very small dose you can give. Or if you're giving even 2 units per hour, imagine it's not very big insulin. So when you're changing the basal rate, if you want to change the basal rate, for example, if you check the pre-breakfast and if you check the pre-lunch, and if the sugars are going high in the pre-lunch, then you know that there is a problem with the basal rate between the breakfast and the lunch time. And if you want to change that, when should I change the basal rate? If my pre-lunch sugar is high, should I change it at pre-lunch time or should I change it little ahead? So that is where this slide will show you that if you change the basal rate, it takes at least 2 to 3 hours for the things to go ahead. So if my pre-lunch sugar is high, I should change the basal rate 2 to 3 hours before that, so that I will get the optimal result at that time. Okay. Yeah. So when you look at basal rate, how to check it? Very simple things. You can divide the entire day. First thing is fix the fasting first. Old dictums. Look at the night time. Very less interference. So you look at the fasting glucose in the morning. Check the post dinner sugars, and if you see that the sugars are going down more than 27 milligram per deciliter, you can decrease the basal rate by 10%. If the sugar is going high, you can increase the basal rate by. So you can then divide the entire day and night into different segments, and then based on the sugar rise and fall, you can change the basal rates accordingly. Yeah, go next. Yeah. Now another beautiful feature about insulin pump is temporary basal rates. Why temporary basal rates are required? What if somebody is going for sudden unannounced activity for exercise as a children, their day is not planned, their day changes and everything. So that is where you can do. What if somebody is on short dose of steroids, particularly with the adolescent girls, the sugars are fine, and suddenly you see the sugars are going wrong. Most likely can be one of the reason can be menstruation. So even during that time also you can set the temporary basal rates as well. So you can set the temporary basal rates for during that period of time. Illness, stress, these are the activities where your basal requirement can go high and low, and that is
Dr. Vinay,
Ma'am?
can I interrupt here?
Yeah.
Just for 1 second. I think this is a very important additional point. And we see young people living with type 1 diabetes, and obviously they want to run, they want to do professional sports, they want to become a basketball player, marathons. And unless and until this can be done, if they can manage their blood glucose levels as per their body's requirement, they can suspend it, they can go on a very low basal. This gives them the freedom to live just the way they want. And we may say don't have alcohol, but we know that at a certain age they're going to party, they're going to experiment. What we can do is give them safety. What we often see with the girls, and he's absolutely right there, there's a whole curve, there's a menstrual cycle, and that is something that's going to happen every month of their life. So there is a initial phase, there's a luteal phase, so you'll have, each girl has a different time. So premenstrual phase is usually where there is very high insulin resistance and there is low insulin sensitivity, and the requirement suddenly goes up, and it becomes very difficult to manage this part. Other than this, even insulin resistance is usually high in the mornings and insulin sensitivity is high in the evenings. So requirement, even if you do the entire calculation and boluses, it is different for different times of the day. All that becomes very difficult. See, if we are not aiming perfection, it's a different story. If we say that it's okay, you are living with a HbA1c of 8 and 9, you're living, you die after 40 years, you have complications, and we are okay with it, then the story ends there. But that's not, what if it happened to us? What if it happened to my child? Then we would want people across the globe are living with type 1 diabetes a life of 90 years, 80 years, 100 years. And if longevity in India, do you know for type 1 diabetes, an average lifespan is less by 30 years in India? An average person is living only 35 years, which should have been at least 75 years for rest of the world. Imagine a progressive country like ours, and our children are reducing their lifespan. And whatever life they have is life with complications. only because we are not giving them physiological therapy. At least today, the country, hopefully, we are still struggling, is moving on to basal bolus and monitoring. But now we have these amazing tech solutions. And if we can give them a perfect physiological outcome, they may seem like points in a slide. But if you see a person living with it, if there is examination time of a child, and that child in that period नीट का एग्जाम देना है, बहुत stress है, the requirement changes. रात भर जागना है, पढ़ना है. Are we going to deny all these basic needs and rights for a person living with diabetes? And that is where having technology like this, especially this, the new 780G that we are talking about, and that will come to again. Why that? Why are we talking about that? But that gives you almost like perfection artificially, what would have happened internally. So these are not just good to have. I'm just trying to say these are essential needs for a person growing up. If you reflect them to yourself as a parent or a person, you will want these facilities in your life. And if you would want them for yourself and your child or your brother and sister, you would should think of them as an option for your patient. Then, of course, exclusion reasons can happen. For this reason, we can't do it, all that. But I want you to just, I interrupted you, sorry, but just to emphasize that this is a reality. I see it every day, and it's very stressful not to be able to cope with it. And I would just like to add here the extreme reduction one can have with severe hypoglycemias. There was a study which reduced the number of severe hypoglycemias. If you've ever with experienced hypoglycemia, I don't know if anyone in the audience has, but there are now hypoglycemia simulators, not stimulators, simulators. If someday you get a chance to be in it, it feels as if the whole world is ending, right? I have lots of
Very
people with
terrible.
diabetes in my family. It's a horrible thing. You're like, you're sinking. So it's not just, okay, hypoglycemia ho gaya, sugar khali, theek ho gaya. Every hypoglycemia saps your mental, physical energy. And a severe hypoglycemia will lead to hospitalization. Every hospitalization in a ICU with 72 hours minimum is a bill of 50,000 rupees. And if it's a low cost, say it's a low resource family goes to a government college, 3 days of missed wages, four people living
There it
there.
will not be in 3 days, one
It
week,
will be
two
much
weeks.
longer.
So we have to
So,
educate our
so
doctor
I'm
students
just
also,
trying
no?
that everyone should think of this. I mean, it's not just a good to have. If suppose pumps were free, let's say pumps were free, wouldn't we give it to everyone? Right? Suppose I had type 1 diabetes, wouldn't I use it? So, if we understand the science and the need, and then of course we can exclude for this XYZ reason. So, please, as a workshop, I would like you all to understand what are the advantages. Earlier,
So
it was
I will
just
add something.
insulin, and yes, your
I'll add something.
experience.
So what I understand so far is we must differentiate between therapeutic treatment and physiological treatment. So when we see patient and give them treatment, maybe multi-dose of insulin or three, that is a therapeutic. Means we are just trying to control the blood sugar because that is the indicator which is guiding us. Itna insulin de do. But when we talk about the insulin pump, now we already know patient require insulin. So now we are setting it very close to physiological replacement. So the dictum is if insulin has to go in the body, it has to go like a physiological only. मिक्स स्टार्ट बिजनेस जब से आ गया ना तब से सारा काम मिक्स हो गया. So because it was easy, it was easy for us कि दो शॉट लगाए मिक्स स्टार्ट के और एनी प्री मिक्स इंसुलिन एंड अब अस्पताल नहीं जाना पड़ेगा. अभी मैं बीमार नहीं होऊंगा, बस उसी पे ही
But
जिंदगी खींच
that
दी.
is why the lifespan is just 35 years.
तो
No?
इसलिए हम लोगों को और डिफिकल्टी हो गई समझाने के लिए कि पंप क्यों लेना है, क्योंकि वो बोल रहा है मेरी गाड़ी चल रही है मैं क्यों सर्विस करवाऊं. सर्विस स्टेशन तो पैसे लूटता है. हमारे को बचपन से सिखाया ना गाड़ी का सर्विस नहीं कराने का, उधर जाओगे गाड़ी धोके देगा पैसा पूरा ले लेगा. So we have to understand therapeutic and physiological. Once you understand these two things, then you can recommend anyone pump why you need a pump. Then pump experts are there, they will take it over, they will educate, train everything. But basic is this: car with a carburetor and car with a multi-point fuel injection system. There is a difference. Na? आज की तारीख में, do we see anyone pushing car on the Bombay roads? Nobody will see ever, because now they all come with multi-point fuel injection system. So that is what the pump does. It gives multiple entries. It delivers multiple small boluses throughout day and night, day and night, day and night. You know, so that makes the difference. And more smaller the quantity, more better the results are. So the insulin requirement goes down, and so many things happen. So I
Please
think
go
we
ahead.
can
Yes.
take more on this.
No, ma'am, here I wanted your input here, ma'am. Like when we are calculating bolus insulin, it is natural, you know. I mean, because of lack of time and lack of things, we write fixed bolus doses. But now imagine somebody with type 1 diabetes. The bolus dose depends on three factors. At what sugar level they are starting their meal. Should my bolus be same? Second thing, every day my breakfast changes. How can my bolus dose be same for all the breakfast? So these are the two challenges that can be overcome by bolus calculator, and it is not only for the pumps. Even there are apps available on your mobile phones where even for your multiple daily injections you can use bolus calculator. There are
Yes.
many.
So I totally agree. So there are three factors. One very common error that occurs because we don't have time or orientation for patients is that this is a missing link in care. So there has to be, if I have to take, so for example, if I have to take a bolus right now, if I'm going to eat, what am I going to first do? So I'm going to first count the carbs in my plate. Then I'm going to check my blood sugar level. I know my ICR, ISF, or if I don't know it, then as he said, they're very good calculators. If nothing else, I will just take a calculator in my phone. I will put in the TDD. It will calculate for me, put my blood sugar level, I will put my carb count, and it will tell me how much insulin to take. That is the way we do it today for people on basal bolus. Yet it is not fully accurate because we may get the right bolus dose because it has a correction bolus as well as the prandial bolus together. But the meal pattern, the content of the meal, if you're having a high fat meal, high protein meal, the activity, how much is the insulin on board? When we are taking a basal bolus, it's very difficult to calculate how much insulin is already in my body when I'm taking the meal. So, am I giving that insulin on board as a thought? But here, when it happens in a pump with the bolus wizard that is being used, AI has transformed everything and that does it on its own. In addition, it has many features. So, point being that this is something every child needs to do. And let me share with you that I have children who are laborers, who are children of laborers in a field, and they are also doing this. So they are sitting there, ताटात काय आहे, ते carb count करायचं, sugar check करायची. We have made grids for them. Then they are counting, and then they are injecting the dose. Because if they don't do that, you don't get a normal. Then you're just taking basal bolus and getting a 9 HbA1c. You can do the same with the pump, previous pumps, if you didn't know what to do. Hence, this built-in system. I think good technology comes for very lazy people. So, but it has great outcomes. I wish I could give this to every child. In fact, let me add here only anecdotally. Earlier, I used to think, and I have changed, and I think Dr. Suresh played a major role in changing my thought process. I used to think my children who come from low socioeconomic strata, and I have so many of them, and I used to think this is a fancy thing for rich people. Right. I used to say I can give them the best pump in the world, CGMS in the world. What will they do with it? They're illiterate. Now, with the new pump, I have realized after I understood its working, learned it, and I was in one of his workshops where I realized that how beautifully it works. It is probably the best thing for the lowest literacy, the most incapable person of doing all this. In fact, if you're very capable, very smart, you can do these calculations, you can probably do without a pump. It is the ones who can't who would benefit amazingly. So I've been since then championing to all governments that basal bolus to mang rahe hain, pump do abhi bachcho
So,
ke.
Archana, thank you very
So
much for
thank you for that
mentioning that,
changing.
and that really inspires me. And what now I am thinking is, there is a suggestion for you. You have so many children, right? Company sitting here. Why can't we make a protocol, and every child let them have experience 1 month this pump 780G. So in their lifetime, they will have one experience of using a pump, and within a month you will get HbA1c less than at least it will reduce by 2% definitely. So even if we can run that pilot project for 100 children, one tell them don't buy, everything will be free for 1 month. So in 1 month, this autopilot system will show them that there is a possible, because many patients have realized that my sugar will never come to normal. I used to see a lot of patients in Surat, here, there, everywhere. સાહેબ મારા તો બ્લડ શુગર 300 નોર્મલ છે ફેમિલીમાં 300 છે. हाउ कैन इट बी, ही वाज सो श्योर. बोलते मेरे घर में सबका ब्लड शुगर 300 है. मींस गांठ बांध ली है, बोले डॉक्टर को दिखा के फायदा नहीं है, मतलब 300 में उसने सेटिस्फेक्शन ले लिया अपना. अब what can you do, you can't do anything. So those children, no need to buy it, just one pump,
I agree.
let them use it and document it. Then we can show this data to 1,000 children or 1,000 places. Keep these children treated 1 month and they show this. Choice is yours. People can arrange funds from anywhere, see crowdfunding, this that, so many. लोगों के पास इतना पैसा है,
Even
उनको
I
मालूम ही नहीं किसको देने का है.
CGHS
So
is
पैसे की
also
कमी नहीं है.
refunding currently. It
Yeah,
is being
and
reimbursed by
yeah, yeah.
CGHS. Yes.
So government तो जब देगी as a human being or as a caregiver or caretaker, what can we do together? You know, that's important. Even you people are not using his pump is fine, but today you, when you walk out from this room, you will know you have learned something which can change the life of a child. You know, that is what our
Absolutely
commitment is
change.
here.
And lower the resource, the more the change, the more dramatic the change that's going to happen. How to get the money for it is a challenge, but it's worth it. It's once in a lifetime.
I think
Challenge, see, life is itself is a challenge, you know, but it's not impossible. Money is not a problem. Thinking about money coming from your past, because मेरे पिताजी के पास पैसा नहीं था तो मतलब दुनिया में किसी के पास नहीं होगा, not that way. That is all past. The money is a conversation. Money is actually nothing. Some zero zero इसके अकाउंट में, उसके अकाउंट में, या मेरे अकाउंट में, हाथ में कुछ नहीं है. So it's a conversation. But when we tell them कि see, many of the doctors I have seen before prescribing pump, they will say बहुत महंगा है, आपको जमेगा क्या? When you are talking only like that, why will it जमो for him? वो बोलेगा क्या डॉक्टर साहब फालतू आइटम बता रहे.
पर
So
आपकी बात
when we
से
recommend, we must recommend. It is not for you, it's your future. One child goes to CRF, like as you said, na, the 20 years diabetes. See, type 2 diabetic can live with the blood sugar for 30 years, 40 years. बहुत कम उसको कॉम्प्लिकेशन होंगे. बट टाइप 1 अगर 10 साल भी अनकंट्रोल रहा तो डेफिनेटली ही विल हैव almost close to CRF. So I see such children, you know, they come from different places. The life is terrible. So the pump is for their future. They're investing into their future. लाइफ इंश्योरेंस है उसका. शादी करनी है पंप के साथ, सो लाइफ लॉन्ग चलेगा, उसके साथ हमेशा चलेगा, एंड दे विल डू वेल
and
provided we are sure कि this is going to work.
and your point is also reminding me they have actually spent that much of money on hospitalization. खेत बेच दिया है लोगों ने, you know, they have taken money on interest. मंगलसूत्र बेच के बच्चों को करवाना, मतलब that extent it happens. So it's a very relative term, and it's time we think of what would that investment be like long term, not in just longevity but definitely quality of life. I think that's another thing we have to really talk about, right? Dr. Vinay, you want to finish
And
this?
if they are ready, no, then a discussion can be set with the parents and company and
Of course,
all,
there
you know,
can be
and
low
it
interest
is
loans.
possible.
So
Yeah,
many things are
so many
possible.
things are
Yes.
there, so many people who can fund their
Contribute.
people.
Yes,
Yeah, yeah.
that is true. As long as we are sure why,
Yeah.
then we know that it can be done. Please go ahead,
Yeah.
Dr. Vinay.
And I think, lot of you, when you will go for lunch after this, so try to, I always say, don't count, gamble with the carbs, okay? Because nobody's perfect in the world, but when you start counting or gambling with the carbs, you realize how much you are eating. And that is very important message as a education, ma'am. What do you think is? Because when you see at home, we don't eat more than 10 different types of foods. We hardly eat maybe same thing. So if they know these are the 10 different foods I'm eating, your 80% job is done. And I think that is more important, isn't it, ma'am?
Absolutely, absolutely. Carb counting is an absolute necessity. It has to be simplified and it has to be applied. And I think if you try it yourself, you will realize that how essential. I'll give you one example. 25 grams of uh, wheat flour ki chapati is one carb count. That is 15 gram of carbohydrates. We think, okay, I just having 15 grams of carbohydrate, but that chapati is just ittusi, right? So yesterday, if you had dinner here and you count your carb, that naan that you're going to have for lunch today is probably 3 to 4 carb counts. That 60 grams of carbohydrates has just gone into that. So if it's not an easy calculation because visually we are not trained for it. And if we have technology that can do it for us and calibrate it,
Or maybe we have to have some study on the chapatis in India. The chapatis can be this much also.
exactly.
If you
That's
go
why I
to
said
Haryana and all,
flour.
it can be this much big also.
Exactly. That's why
So
flour content
yeah,
was
so the
important, not just the size.
volume or
Yes.
size is important of plates.
That's what my kids say. Ma'am, ittu sa khaya hai. मैंने कहा, ये ittu sa nahi hai. This is 2 carb count. When we divide their carbs, they say, okay, हम तो 4-5 chapati खा लेते. 4-5 chapati is like what? 60, 70, 80 grams, 100 grams, 115, one meal. And we don't realize it.
Young children need
Growing
food
age.
also. Na? You can't stop them. You can't tell the children कि don't eat. उसको 3
Especially
चपाती खानी है, उसको एक्टिविटी करनी है, उसको लड़ाई झगड़ा भी करना है, बच्चे दिन भर कुश्ती भी
And
करते
I
रहते
want
हैं.
you to imagine one more thing, just to not because we are on a pump workshop and we want to talk about pumps only, but because I do this every single day with thousands of kids. Imagine हर वक्त खाने से पहले, no matter what, if I just opened this, had it. But if I had diabetes, I would have to think how many grams is this? Is this sugar? Is this carbohydrate? This is protein? Is it fat? Imagine every bite you put into your mouth is counted, calculated, scanned for protein, carb, fiber, and then adjusted for dose. And oh no, I can't have it now because I don't want to take a shot. So my girls will go to a pani puri wala, calculate how many pani puris they want to have, check their sugar, count those carbs, take a shot, and then have pani puris. Now the pani puri wala now knows how to count the carbs in the pani puri. That's how many times they have done it.
पानी
So
पूरी वाला also diabetic है.
now he's learnt it. He's so used to it. But if this could happen this way, that they didn't 24 by 7 have to do this, and I think that would
But still,
change their life amazingly.
as a Indian, our lifestyle, if you see pattern fix ही है. खाने पीने का वही रहता है. सुबह दोपहर शाम हर रोज का वही रहता है. We are not changing. If you see, go back and check कि forget about this conference setting in your regular home. वही बाई आती है, वही खाना बना के, वाइफ तो मेरे को नहीं लगता किसी की खाना बनाती है आजकल, पर
नहीं
वही
बनाती.
बाई आती बनाती
किसी
है.
किसी
अच्छा,
के हस्बैंड्स भी
हाँ,
बनाते
किसी
हैं. Why the gender wise?
तो
Why
वही
not?
खाना रहता है, वही सेटिंग रहती है, सब वही रहता है. तो इसलिए डायबिटिक के लिए डाइट में कोई ज्यादा झमेला नहीं है.
Hmm.
हाँ, बट वेस्टर्न वर्ल्ड में ये जो डेटा सब आ रहा है ना, वेस्टर्न वर्ल्ड का है, वहां पे बहुत लफड़ा है. अभी उसको ये खाना है, अभी उसको वो वाला फिश खाना है, अभी उसको वो वाला आइटम खाना है, उसको आज साइकिल चलानी है, कल उसको स्की करने जाना है. अपने क्या स्की विस्की होता है, गली के बाहर चले गए तो वही वीकेंड हो गया उसका.
But
So
what Dr. Peter said in the morning in his opening talk was very important, that one thing focuses that we have less protein. Because we eat too many carbs, the only thing in the diet is that we really have to be carb conscious. But we have moved away from the topic. You were saying, so we
Yeah.
can finish this
Can
we can
Done?
sum it up
and we
quickly.
can ask their
I think
questions. We
5
have
minutes or
5
so.
minutes, yes.
Yeah.
You can summarize verbally and any questions. I think that will be more important. Any questions?
Ma'am, I think it is a technology. So if
Hmm.
anybody wants to
Do
experience,
you want to experience the pump? You can
does
really
anybody want to
see
put
everything.
infusion set?
Just
So can you
let
come
the
here?
people hold it and see.
You
उसको
can
आप
give
जरा
them
हाथ
these.
वाथ लगा के देख लीजिए
आपको लगाना है?
कि
आप लगा भी सकते हैं.
देखा है?
दिखाइए
ये
सबको.
दो चीजें बता
Can you
दो.
just
So these
give it
are
to everyone?
insulin syringes which contains insulin and it goes in the pump. And there is this one is the quick set or we call it a cannula. तो इसमें cannula है which delivers the insulin and it can be of two size 6 millimeter depth or 9 millimeter depth according to the child's condition कि whether he is very thin slim है तो 6 millimeter लगेगा नहीं तो 9. So that is our purview कि how to choose and all. So it's a almost 60 centimeter long wire is there or cannula is there, so he can hide and keep it anywhere. This sticker usually stick for 72 hours, and we recommend it should be changed within 72 hours. पर अपने यहाँ तो देसी लोग हैं, एक हफ्ता भी चलाते हैं, 10 दिन भी चलाते हैं ना. जब तक उधर एब्सेस नहीं हो जाएगा ना, मेरे पास ऐसे भी पेशेंट है, बोले सर अब जब नेक्स्ट वीक नहाऊंगा उस दिन चेंज कर लूं क्या, ऐसे भी रहते हैं ना. सो ऑल दोज आर पार्ट एंड पार्सल ऑफ द गेम, बट डिक्टम इसकी 72 आवर्स में चेंज करना चाहिए, अदरवाइज इट विल डिलीवर इंसुलिन, बट इट विल डिलीवर इंसुलिन इन wrong place, or it will be collected but not delivered in the skin. So this is very important. Children they think कि हाँ चल रहा है तो चलने दो. तो थोड़ा ऐसी दो तीन चीजों का ध्यान रखना पड़ता है, which we educate children to do it and they do it. So these two things, and one battery is there, which is a pencil cell battery available everywhere, and it doesn't require anything else. And the best part, it comes with a warranty of 4 years, 5 years, 4 years. So one of my patient recently, he was in Tanzania, and I put him on pump. So he, अच्छा एक उसमें then he wanted to send the pump back because pump got failed. Pump fail भी हो जाता है, तो उसको pump replace करके दिया. So it gets replaced immediately, company replaces it immediately, there is no issue. So that is also a good part of it. Other equipments are difficult to replace, but this is replaced
So,
easily.
so any questions? Last 2 minutes. Otherwise, we will each give a take-home message and we will end the session. Any questions from the audience? I think it's a new topic, relatively new, because we do not have pump users in the audience. So anything, Dr. Vinay, anything you want to say? We will just conclude your take-home message for everyone.
So I think is that as a technology and you're the doctors, I think so. Lot of times I would request you to feel the technology. When you feel the technology, that is where you will realize its potential. And I would request you to give it as a try to your few patients. If somebody has with type 1 diabetes and all, I will tell you it will dramatically change their lives, as well as it will teach them about diabetes, how to manage hypo, how to manage hyper, how to take correction bolus, how to count the carbs. Because I will tell you, when you start counting you will eat less. So that is also you are indirectly telling them what to eat
eat
and what
better,
not to
better
eat.
control.
That
Yeah.
is the one thing I think my key message, ma'am.
So yours.
So the my key message is therapeutic and physiologic, बस उसी पे focus करने का, everything will be same, everything will be fine.
Absolutely. My last message is that it's a great option. And just because we have a mental block about finances, let us not restrict ourselves from offering it to our patient. You never know, somebody who looks very humble in their financial condition would have the motivation to actually spend on it. They could have some ancestral property they're willing to sell to give their child a pump. You never know. At least offer them that option, because it has a dramatic change in the quality and quantity of life. So I think this is something I would like to emphasize. Right? Thank you.
Thank you.
We are about to start an important panel discussion on gaps in diabetes management. I would like to introduce our esteemed panel members and moderator, uh, Dr. Balaji Chidambaram. He's a treasurer RSSDI Tamil Nadu chapter. He's attached with Meenakshi Hospital and Diabetes Specialty Center. Awarded fellowship in Diabetes India 2023 at Indore. His faculty in various conferences, RSSDI, the BED, 3D Con, and Code. Teaching faculty for various certificate course in diabetes for doctors and paramedical staff. Please welcome Dr. Chidambaram. Our next panelist is Dr. Chand Patel. He's a consultant diabetologist and foot care physician and diabetes care multi-speciality hospital Latur since 2009. He's a life member Research Society of Study Diabetes India, RSSDI. Our next panelist is Dr. Harshpreet Tuteja. He's the director of Sardar Ranjit Singh Memorial Hospital and Research Center. Please welcome Dr. Harshpreet on the stage. Please welcome Dr. Tejas Kamath. We'll start the discussion now. I would like to introduce our moderator, Dr. Alok Modi from Thane. Please hear it from him.
So, very warm good morning. Welcome to everybody. At the outset, I would like to thank the organizers, Purvi and Manoj, for this wonderful opportunity. And I would like to once again welcome the esteemed panelists here. And we are going to cover a very important aspect and topic, which is very relevant for clinical practice. Now, this is a huge topic, very difficult to cover in half an hour, but I'll try to split it up into four verticals, which I thought are relevant and meaningful. And I'll try to keep a more involvement from the audience as well as the panelists, and I'll try to speak less in the whole discussion. So just to show you some data, you can see there is a lot of literature on diabetes gaps in coordination, and there are a lot of complications because of poor management of these gaps. Now the problem is the frequency of these problems remains quite high, despite of the fact that there is a lot of work being done, a lot of publications are coming out, a lot of esteemed diabetologists are working. The reason is we don't take pains to identify the gaps. We just go ahead and implement therapies and management strategies. So there are a lot of papers here. You can see this barriers and solutions to diabetes management, published by gentlemen. The authors are well known to you, like Dr. Jyoti Dev, Dr. Kalra, and all. This is an Indian perspective. This is another paper coming up and telling you that there are enablers and barriers to effective diabetes management. This was a multinational investigation, shows there is a huge amount of gap and data. This is another data from the Journal of Diabetes Research from South Africa, says there are a lot of treatment gaps found in the management of type 2 diabetes in a community health center. There's another paper here, Gaps in the Type 2 Diabetes Care Cascade. This is from the South Africa's National Health Laboratory Service. So there is a huge amount of data. I can keep pouring up data saying there's a huge thing between taking the apple and putting it in the mouth. There's a big gap between, having a morsel in your hand and actually going in the mouth, or having it in the mouth and getting digested. There's a big gap there. So we need to try to cover that. So I've tried to cover it in these verticals. There is a delayed diagnosis in many patients. They come with complications to you rather than with a diagnosis of diabetes. They come with their own screening methods from corporate labs, and they are not the right screening methods. There are different diagnostic criteria followed by different people in different parts of the world in different areas. There's nothing like a routine screening. People do it by force because of insurance or some other reason, and people like us get them when they're due for surgery or cancer or some complications. And you know the disparities in SMBG reporting and HbA1c. So there's a huge gap. So to introduce you back, this is the wonderful panel here who's going to discuss this, and I'll be posing a few questions to them. You're welcome to barge in and join in. So I'll just move through this slide. These are the verticals I'm going to handle: diagnosis and detection, gaps in individualized care, gaps in social media. I didn't want to talk about other things, but I thought this is more relevant today, and gaps in patient counseling, because we really don't do that much. So let's start with the first vertical here, gaps in diagnosis and detection. So the first question to you, Balaji sir, is, Dr. Balaji, what according to you are the gaps in diagnosis and detection that hamper the progress of a patient of diabetes?
So thank you, Dr. Modi sir, for giving this wonderful platform. So to start with, so we can just say the gaps can be divided into three aspects. One is as per the
Sorry to
patient.
interrupt you. We have half an hour here, so
Sorry.
we have four verticals. So I'll try to
Sure.
restrict each vertical to 8 minutes, and I've kept only two speakers per vertical. So let's just move it
So
fast, and
I'll
I just
just
want 1 minute for the audience on each vertical.
be brief. One is the patient aspect of things. What are the barriers? Is poor education and the healthcare system, and that's the base of each and everything which lays the thing. Secondly, the healthcare system barriers or gaps. So there are a lot of inertias, as Modi said, the lack of clear-cut criteria, lack of evidence-based things to have perfect setting to have this test to do a diagnosis and things. And lastly, the physician barriers. So lot of gaps are there, even among the physician treating physicians. Which test has to be done and what has to be done to diagnose and how to take forward to a diabetic patient.
Thank you, Dr. Balaji. Dr. Chand, now that Dr. Balaji has elucidated certain gaps, which he feels is very relevant from his experience and practice, and he has a huge experience, how do you think we should bridge this gap in diagnosis and detection? Let's stick to diagnosis and detection. What do you think we should do so that the diagnostic part gaps can be reduced and the detection of diabetes can be done much earlier than it is being done as of today?
According to me, there needs to be a uniform screening tool, something like Dr. V. Mohan has developed the Indian Diabetes Risk Score, which is very relevant to the Indian population. So while going in the public and doing screening at mass levels, if we apply the Indian Diabetes Risk Score and we screen the population according to the risk score, there is a high chance that we get the positive from that. And regarding the detection at the rural level, we are still lacking a lot behind. Nowadays the sedentary lifestyle has increased in the rural areas and the screening is absolutely not there, so we get the patients coming from rural areas with very high HbA1cs and all, and in the young population. So it should be like a public private partnership. The government has to take some initiatives at private level. We have to do some camps and we have to implement the risk scores and screen for the maximum positive values to come out, so that we get the maximum detections from that.
Two suggestions from the audience. Would any of you like to share about, let's stick to this vertical. What do you think could be done to bridge the diagnostic gaps? And what kind of solutions do you envisage we can do to get better patients on board for diabetes and early pickup and early management? Anybody from the audience is welcome. Yeah, please, Vikram. Can we have a mic for him? We will come to that little later. Now, this is purely on diagnostic part.
Yeah.
Awareness will come a later. So,
Yeah.
what do you think we should do so that the diagnostic areas can be improved so that the pickup is? So, what I'm trying to say is, people have diabetes, but some of the diagnosis is not done, though he is aware.
Yeah.
What do you think should be done so that the diagnosis is quicker, faster, and more
So
accurate?
take the diagnostic facilities right up to the door of the patient, so we can do more
Absolutely.
of community diagnostic
So, you mean something
camps,
like a mass screening?
mass screening.
Absolutely.
Yeah, and not only for adults but also for children of diabetics.
Absolutely. That's very
because that
important.
is where you will pick up the juvenile ones early.
Absolutely.
And more importantly, tie up with various corporates and get the sponsorship for these things, because it has to be affordable healthcare.
Absolutely. Any other suggestions, sir?
One point I would
Please,
like to
please.
add, for cars, there is a rule that for you to renew your insurance and all those things, you
Right,
need PUC every yearly. So that's why I want to, if it can be done at a larger level for health also, that all your employees should get screened annually. A health checkup should
That's
be
a
must
very
for.
good suggestion, and I
It
think we
must be
should
a
send
must
a.
for all the
That's an
employees.
excellent suggestion. Why don't you drop in a mail to RSSD and we should
Yes,
incorporate it? That's a
yes.
brilliant idea. Uh, from my experience, I'll tell you, I get a lot of patients who come for fitness, for cataract surgery and other things, and I realize they just do a random sugar, or they expect you to do it on a glucometer. They don't even get a proper diagnostic workup done. And on the other hand, you have patients who get some 40-page reports from Thyrocare and reputed labs, but then you keep hunting for fasting. You get fasting or post lunch, but you don't get both, or you get only HbA1c. So that's another thing that and here I just wanted to share this, and thank you Purvi for this wonderful topic, Hatke topic, but very nice topic. Assessment of diagnostic gaps in criteria from Nigeria, Uganda, and India. And they've said something very nice that patients move through multiple areas. They should be interconnected. Unless you have an interconnecting system, the data gets lost from one area to the other. And patient assumes that he was a diabetic, so you're supposed to know he's a diabetic. There are no proper, I mean, you all know that HbA1c is not standardized yet. You get different reports from different labs. So I'll stop this here. I'll just show you another data here, gaps in the type 2 diabetes care cascade, South Africa's National Health Laboratory database. And as you can see, from 100% diagnostic till the glycemic control is just 8%. So much gap is there is huge, and we should realize that there is a lot of ice under the sea. Now let's move to the second vertical here, and that is gaps in individualized care. Now today is the era of precision medicine or personalized care. How much personalized care are we doing, or are we just copying pasting the guidelines onto the patient? This is something that I would like to ask. So Dr. Harshpreet, would like to have your suggestion. Why do you think personalized care is so important, and what is your understanding of precision medicine?
So exactly, so personalized precision medicine and personalized care is very much important because in diabetes we are not treating only hyperglycemia. We have to not just control sugar; it's a metabolic syndrome, and we have to take care of each and every metabolic component of the patient. So if a patient comes to me, can be only a newly diagnosed diabetic, can be diabetic with dyslipidemia, can be diabetes with hypertension, with fatty liver. So every patient is individualized. So precision care and a precise medicine with a combination of medicine is must in all the patients. That's why precision medicine is important, because we have to not just treat sugar levels, we have to treat the metabolic component of the patient. The patient come with can come every patient can be a varying patient, can have multiple apart from the diabetes metabolic components. So that's why comes the importance of precise medicine, so that we should target not only the sugar levels but the metabolic component of
So you
patient.
mean to say two patients having an HbA1c of 7.8, fasting of around 110 or 120, and a post lunch of 220, and a blood pressure of 150/90 should not be given the same prescription, right?
Exactly,
So that's
exactly.
where individualized care is important, and that makes it because which one will land up with the cath lab first, you don't know. So
No,
that's a
nobody
different
knows
thing.
that.
That's a very important point that we should know. Dr. Tejas, what do you think is a reason for a difference in India and other countries? Do you think there's a gap between the way we do precision medicine in India and other countries? And do you think that there are methods other than technology, or do you think technology is a way out to get precision medicine implemented in India?
Yes. So when we talk about individualized therapy and precision medicine, I think this starts with the right diagnosis and screening of complications and comorbid conditions that a patient has. As Ashprit said, so we have to screen the patients for hypertension, dyslipidemias, fatty liver. Also look at complications at an early time. Screening of complications, diabetic retinopathy, neuropathy, do a basic ECG, echoes, look for heart failure. All this has to start at an early time, and not only a glucocentric approach. And we are in an age where we have multiple modalities at our disposal. There we have AI screening, backed AI fundus cameras, which will help in early detection staging of retinopathy. We have CGMS. All these tools have to be taken care of. So it is important that physicians are aware that these tools are there, and they are also aware how to use this in our practice.
Wonderful, very rightly said. Any inputs from the audience? I see a lot of bright faces here. Anybody would like to share any experience, or maybe a one liner or a two liner about precision medicine? Anybody wants to say something? Yeah, yeah, please, Vikram, tell now.
So, the treating clinician should impress on the patient psyche that I just don't care for your glucose levels, I care for your entire body, the mind and the body both.
Like a holistic approach.
Exactly. The patient should get confidence and should be, you know, uh, very much convinced that you're not just for his lab reports, you're for his overall well being.
We should thank him because he's an ENT surgeon and he's been attending the meetings in the last 2 days very actively and participating. Thank you, Vikram. But just give you a quick question to the audience. You have a patient with HbA1c 8.7, two patients, fasting 110, post lunch 160. One person has a blood pressure of 230 by 1, or probably 150/90. The other person has a blood pressure of 130/80. The first person has an HbA1c of 9.0. The second patient has an HbA1c of 7.8. Vikram is going to treat one patient. I'm sorry. Let's Balaji is going to treat one patient. I'm going to treat another patient. One of the panel is going to treat. I managed to get the BP under control, but I don't manage to get the sugars under control. He manages to get the HbA1c under control, but not the blood pressure rightly under control, right? So this is precision medicine. 5 years down the road, will my patient end up in the cath lab or will his patient end up in the cath lab? A quick answer. Whose patient will end up in the cath lab? I'm good in controlling blood pressure. He is good in controlling HbA1c. Tell me which patient will land earlier in the cath lab? Okay. The right answer is the one who gets the blood pressure under control delays the cardiac complications. So that's a myth. It is not the sugar control, which is not important. I don't mean that, but blood pressure control is more important. There is a lot of data on that. So every decrement of blood pressure by 2 millimeters of mercury makes a hell lot of a difference. And what's important in HbA1c is not the control of sugar, it is the glycemic variability, which is the fourth dimension. That control is more important. And the new metric today is TIR, time in range. So having a fasting of 110 is not important, but having a range between 70 to 180 is more relevant. So I'll just show you some paper here. Again, back to this Uganda, Nigeria data, the enablers and barriers paper. Now here they're saying that transforming diabetes care with precision medicine is the game of the day today. And you'll find a lot of talks today on precision medicine. And I wanted to show this because I do a lot of AI work. This is precision medicine and diabetes. See how your prescription changes. And if you look over here, this is the data, couple of good amount of prescriptions were pushed into AI, and AI could tell the clinicians there after feeding all your EHs. You can do it with ChatGPT yourself if you are comfortable. It will tell you that a couple of medicines were not supposed to be given, were given, and couple of medicines which were supposed to be given were not given. So, for example, not writing SGLT2 or a GLP agonist where it is required, in spite of having sugar control, may be more detrimental. And if you look at the ACE and the ADA guidelines, they're very clear today, like very rightly pointed out by the panelists, that it is not a glucocentric approach, it is an organ approach. So the CVOT effects are paramount and the whole work is being done over there. Now let's come to a very challenging, a very mind-boggling and a very interesting topic. And I'm sure this will be a very, lot of discussion here. Gaps in social media. Actually, this can be a weekend talk, a full weekend talk. So Dr. Balaji, I'll put you in task here. Do you think social media is responsible for creating a gap, not therapy? Do you think it's responsible for all the jeopardies in patient care and diabetes?
Absolutely. Social media is it's responsible for creating gaps because when we take the social media, it sets as pros and cons. So only as a physician or as a doctor, it's our responsibility to utilize the social media in maximizing the benefits and minimizing
But the
the.
problem is we don't have time. It's the patients who are
That's the thing.
utilizing
That's
social
the thing.
media.
So because we have many odds out of the social media and also the positive aspect of things. So we have to utilize the positive aspects for creating education and communication and other research aspects of
So you've
things.
opened up a Pandora's box. You have said that there is a lot of problem, but we should solve it. So, Dr. Chand, what do you think? We do a lot of work in conferences. We are forming beautiful organizations. We are part of RSSDI Diabetes India. We are part of multiple API, ACP, and all conferences. What do you think could be done at a national or an international level through these conferences and associations to actually put social media, harness social media, and put it where it actually belongs? What are your thoughts on that?
Yeah, to be very honest with that, we use social media for our own use, or we use only for our own community. That's the doctors' community. Even we are taking the conference, we're educating ourselves or our community. But when you look at the educating the public or the public awareness, we are lacking a lot behind. Dr. Pranjali is here. She shared a video a few days ago on a WhatsApp group with a voiceover of many celebrities. There are different videos if you log into Facebook, Insta, and all, with voiceover from Amitabh Bachchan, Sachin Tendulkar, Virat Kohli, Dhoni, and they are propagating XYZ medicines, and they're telling like it is going to cure the diabetes. And there are a lot of stuff going on the social media, and they are overshadowing actually what work we are doing, and we are not being able to take our work to the public. We are publicizing that amongst ourselves. We know that XYZ doctor is doing a good work, ENT surgeon is doing a good work, or a food surgeon is doing a good work, but our work is not going to the public. We are very much behind in the social media presence in between the public. So as a RSSDI, as Diabetes India, I think we have to overshadow this influencers, those who are there creating wrong information to the public. We have to pass on the right information in a right way, in the right platform. Like somewhere we are lacking behind, let's say financially, to propagate it on the mainstream media. But at least social media is not so costly. We can have that handles. We can have say paid ads on Facebook or WhatsApp or Insta, and pass on the right information, because patient is not aware. They are so naive to all the things. Once you get detected with diabetes, they are receptive to so many information. They're, like you said, it's a Pandora, and it opens up, and they are like so confused which information is right, which is wrong. So that also maybe we have to be open to the patient कि आपको कोई भी information मिलता है, you pass it on to me, you get it verified and right credentials for me, and then you can take it over from there.
So you
And
built up a
right
very,
propagation is very important,
very
I
good
think.
foundation. With that, Vikram, let me give a chance. Dr. Pranjal, would you like to say something? And would somebody else from this side like to contribute in the discussion? I'll come back to you, Vikram. Yes, sir. Just introduce yourself and tell us. Please use the mic. Mhm. Mhm. So you feel the clinician should do that, right? They are not doing it, they should do that. Fine. Understood. Absolutely. Absolutely. Dr. Pranjal, anything?
So I had a patient uh, who was following one ad and he has stopped his medication and he was taking some medicines for prevention for reversal of diabetes, and he had come with sudden loss of vision. So then we realized कि no, नहीं अमिताभ बच्चन ने बोला है and everybody is following, आपने नहीं देखा है Facebook पे, so we are doing this. So then we realized that he has lost one eye because of severe diabetic
Because of
retinopathy.
Amitabh Bachchan.
Yeah. So that's what then we should, actually educate them not to follow blindly any ads or anything.
Absolutely. Vikram?
So today evening, I would like to see on your Facebook page and Instagram page,
Mhm.
not that you participated in the conference, but a short write-up on the gaps. Create awareness because
Otherwise, he's going to complain to Manoj and Purvi. Don't call them next time. Huh?
secondly, the societies can put paid advertisements at least in the
For
newspapers,
that, you need to
creating
write a mail
awareness. Yeah, I will write that.
officially.
But that is one aspect because newspaper everybody reads, and RSSDI or Diabetes India are quite rich to put paid ads, or at least it can come from the corporate social responsibility fund.
Okay, I'll take that in a different way. Just look at this data. Look at the amount of people using WhatsApp and Balch and MySpace and LinkedIn, and you will realize the penetration of social media in the population. It's a general this thing. The conclusion from this study was the role of social networks and the influence of social network is very high among patients. And they've also very clearly written that social networks are causing detrimental damage to the patient's psyche. And the reason is, I'll tell you, it's very simple. You don't have time to take your wife out for dinner and lunch. Somebody will walk in one day and then you'll wonder what happened. Why is my wife not with me? That's because we are not active on social media. Very rightly said that we take out 5 minutes to chat with our friends on various watching CID and other things, but we don't take out 5 minutes to put up things on social media. And there is another important caveat to that. There is something called as a legal angle. You're not supposed to advertise, whereas alternative medicine people are got full rights to advertise and there is no law against them unless allopathic medicine, and that's a bigger hunch reason which I've spoken to many people. They're scared of writing things on various social media because you never know when the regulatory bodies will catch up saying you're advertising. So, that's the reason people like Ramdev Baba and all are prolifically throwing Coronil and other medicines as the ultimate cure and Amrit and all, and you can't do. But there are ways and methods of doing it if you want to do it. And another problem which I feel, which we should do, the organization should rope in the celebrities to talk the right things and not the wrong things. Celebrities are talking the wrong thing because see, celebrities will talk what they are paid to talk. You get the idea. So rather than absolutely. Absolutely. So social media is a very powerful tool, and I know many doctors who are very active. I've got some 6, 7 videos on YouTube, not much, because there is a pain, to get everything done. But then if you start talking, and the thing is, you just don't have to talk messages which people don't watch. People watch social media influencers because they put masala over there. You need to put masala in your this thing, and you need to tell them what is important. And there are so many apps which are charging 80,000 to 1 lakh for 6 months and misguiding the patient, and you're charging hardly 1,000 or 2,000 and you're guiding the patient, but then you suffer, they don't suffer. Okay, let's move ahead now. This is another thing, social media and the management of obesity and diabetes. It's an underutilized population educational tool. There is a lot of work on that. Just go through that at your free time. Now, the last vertical and a very important vertical, which can actually run for another 2 hours, is gaps in patient counseling and diabetes distress. So let me ask to Dr. Harshpreet, Dr. Harshpreet, just listen to this question very carefully. What are the actual gaps and the perceived gaps in patient counseling and diabetes distress?
So, sir, this is one of the most emphasized topic which should be talked on, especially in the rural parts of India about the patient counseling for the diabetes management. I will start with a small example.
Please.
A patient comes to us with a newly diagnosed diabetes mellitus, a young guy of 38, 39 years old. He comes to me, nobody with the sugar levels of 400 or 450, and a wife sitting behind her puts a pad in her leg. तुमको बोलती थी ना कि चेक करते रहो, अब हो गया शुगर, अब मेरे से मीठा मांग के दिखाना, अब तुम कुछ खा के दिखाना. It
Absolutely.
provides a lot of distress to the patient who is already distressed by knowing that he is a diabetic. So you have to beautifully counsel your patient that diabetes is a disease which is going to be with you lifelong. Now you have to understand it practically, and you should not go into reversal of diabetes by 400 sugars. You have to know and learn the techniques how to live with diabetes happily your whole life. So this needs counseling of the patient that diabetes is not a deadly disease if you're going to control your hyperglycemia and the metabolic components. Especially in the rural part, what I suffer with the counseling of the patient is मेरे को शुगर हो गया, अब मेरे को जिंदगी भर दवाई खानी पड़ेगी, मैं दवाई
Absolutely.
खाऊंगा तो मेरे को मेरे बगल वाले ने
And
बोला
more
कि
than that, अभी आप इंसुलिन
एग्जैक्टली
दोगे और इंसुलिन पे हमको जीना पड़ेगा.
जीना पड़ेगा, और डायबिटीज की वजह से मेरी गोली की वजह से मेरा किडनी खराब हो जाएगा. दे डू नॉट अंडरस्टैंड कि हाइपरग्लाइसीमिया इज गोइंग टू अफेक्ट योर किडनी. What they understand is because we are taking long term medicine, the side effect of medicine is that we are going to burst our kidney and the heart. So that's the most important point. That's why doctors are also the culprit in this. We should give proper counseling. Like I have a counseling area, I have a counseling guy who counseling the diabetes, because we don't have time
मैं
in seeing
diabetes
patients,
educators.
but we have a counselor for that. Diabetic educator is much important. So this is the
Absolutely.
most important
You've
part
opened
which
up
I
a
feel.
huge Pandora box here, which is very right. Dr. Tejas, to you. Do you think, because the doctors have a very busy schedule and a tight lifestyle of their own, do you think we can use technology and artificial intelligence and apps to bridge this gap?
So as Dr. Shpreet rightly said, so there are so many gaps in counseling and patient distress, and the challenge that we face is lack of time. So counseling should start right from diagnosis, telling patient what diabetes actually is. It's a lifelong. About medicines, as he rightly said, they are worried about long term side effects, इससे kidney or heart damage होगा, all those nutritional challenges. So many myths, they believe that they won't be able to eat this and that, and as far as fruit is concerned, they only eat papaya and no other fruit. So spending time with the patient is very important. As far as patient counseling is concerned, it's about also about dealing with complication prevention, telling patient not only about telling about glucocentric versus organ protection, all those things. And I think the challenge that most of the physicians face here is lack of time, and that is where the role of AI or apps come into the picture. I think our moderator, Dr. Alok, is one of the pioneers in developing apps is concerned. So I would like to
Mhm.
him to address
Thank you.
this further.
No, but then the human touch is always more important. Before I come to some data here, I just want to show you the challenges. You know, one size code doesn't fit all. Lack of communication, overlook. Let me show you some hardcore data here. This is from Springer's, which show that diabetes and artificial intelligence is beyond the closed loop. There are a lot of references, lot of things, lot of chatbots, and just touching on the topic. Dr. Bharat Sabu, one of our big pioneers himself, has created Mitra. I've created two apps. They are doing wonderful work, but then there's a lot of data here reducing social diabetes distress with a conversational agent support system. But this is something that we talk about. It should be human in the loop, not AI in the loop. You are above the AI. You should use AI as a technology, not to replace you. Now, let me show you some hardcore data that the Pandora's box has been opened by Dr. Harshit. In the Dawn 2 study, half of the people with diabetes had emotional distress. So if you're going to see 50 patients today, remember 25 of them are not going happy from your clinic, not because of your charges or because of the way you talk. They're unhappy even before they have met you, but they are not happy after they meet you. That's the problem. The other problem is women with diabetes report a worse psychosocial outcome than men, and you can see from the data here. This is gender specific over here. Look at the country specific data. Turkey, India, China, and Japan have got a huge amount of discrimination for diabetes compared to the other rest of the world. This is something we're not aware of. Some more eye-opening data here. Majority of family members, even the good clinics where diabetes educators are working, are not part of the discussion. It's just the patient, and the patient. But we forget that the mother-in-law plays an important role. We forget that the neighbor plays an important role. We forget that the office secretary of the patient plays an important role. We forget those things, those relationships. Yeah, please go ahead.
Just one point to add. See, apart from all the high technology and AI advances in the management, all should learn one thing: the patient counseling is the most important part from a doctor, which we can do. Because in India, the patient is going to learn about diabetes more from you. Matlab, they will learn from their neighbors, they will learn from their Google part, but they will never learn from doctors because doctor is not going to teach them. So the most important part which we should see in our practice it, apart from writing medicines and explaining their metabolic component, counseling patient for just 2 to 3 minutes can give a wonderful result to your patient in your
Dr.
near
Harshpreet,
future.
you're right. I'll just come to you, Dr. Balaji. So that's exactly what you're saying. This is what Dawn 2 study have shown. Perceptions of communication between people with diabetes and healthcare professionals are different. Doctors talk, they actually spend time, they feel they have done their job. But if you ask the patient, they say they have not done the job. They have explained to me, but I have not understood. So that's the paradox. You take a feedback from the patient, they say yes, doctor has spent time, but I've not understood. I don't My confusions have not disappeared. And I'll just come to you, Dr. Balaji. This is a youth study, national recommendations by our own people, psychosocial management of diabetes in here. And Dr. Kalra, Dr. Sahai, Manoj, all of them are part of it. And you know what they have given? They have given 94 recommendations for Indian population. 94 recommendations. It's huge. And they have said the top recommendations are SWOT analysis, problem solving, and care attitude. SWOT is strength, weakness, opportunities, and threats. We should work like water, which is we should have a welcome attitude to a patient who's not taking your treatment, who's changing doctors. We should ask. We never ask. We start blabbering. We never ask, what is your problem, rather than we talk. We should tell them truthfully, ki, boss, you need insulin, you need GLP, you don't take it, that's okay, but you need to tell them. We are scared, we lose our patients, we don't tell them. We don't have empathetic approach, we even have a threatening approach, or we have a sympathetic approach, and we don't reassure every time they come back and tell us we are not following your treatment. So that's an important approach. Take care approach, I won't go, we don't have much time here. And I'll just shift a little bit about my experience. I don't pick up hypos on a glucometer or CGM. I pick up hypos because of the performance issues. I've seen people misbehaving mentally. I've seen their performances go down. I pick up renal failure causing hypos in the same prescription. I see EGFRs. I get pointed towards hypos who don't talk about hypos. They check their sugars. I've seen patients with 200 sugars coming down to 150 or 100. That is a pseudo hypo, but it is an hypo. It is clinically relevant, though the value is not there. I pick up people who with erectile dysfunctions very early. People don't talk about it. That's an important part that people don't touch. Even female sexuality, people are scared of talking. A very important aspect of picking up patient care and counseling areas. And insulin is something, like you said, this is a block that I have created. I tell my patient, read it and then come back to me. It makes my life very easy. Beyond patient's life, how many times you change the needle, when do you inject, how do you rotate, a lot of things are covered. Now, before I go ahead, this is a very hot topic, and I'm sure all of you have a lot of data to share. And back to you, Dr. Balaji. You were
So,
going to tell us something
yes,
about
just
it.
one thing. See, as I come from a very tier two town where the use of technology is not being reached to the maximum extent. So, everything, as emphasized by Dr. Ashwit, it has to come from a physician. You have to sit and talk to the patient other than prescribing the medicines. That's the most important part of thing. Then adding with technology will pave a huge way in the management of diabetes.
And when you are sitting in a award show and you're having Shah Rukh Khan and Amitabh Bachchan sitting and you don't talk to them, that's a crime. So Manoj is here. So Manoj, what's your opinion? So please share two lines from your experience about patient counseling. How do you think makes a difference? So can we have the mic to Manoj?
And what topic on insulin?
On anything, it's your on patient counseling and patient distress. Where are we lacking? What is the gap?
I think that's a huge part of managing patients with diabetes today. So we always felt that in spite of all the advances in technology and the kind of medications, we are still stuck at about 20% people reaching their target. Leave alone the fact that we don't even measure the satisfaction, adherence, compliance, and uh, the distress. And I'm trying to get the word that I've been a part of paper with Dr. Sanjay Kalra.
Exactly, I
The
showed that
term
paper.
which we had coined. What was the term that we coined for distress? That there was a term that Sanjay typically comes out with different words. So anyway, to the fact is that we don't measure it, and many clinicians. I think it goes right from the fact that the way we are trained. Um, to be better at conversation with patients. So we've been taught anatomy, physiology, biochemistry, which none of us remember much now. And then we get on to clinical medicine. But nowhere in medical schools we are taught about
Communication.
conversation. We are not taught about empathy. We are not talking about eye contact. And that's what makes a huge difference. Everybody here in this Congress who's working as either a family physician, a diabetologist, endocrinologist, in terms has similar knowledge that has read, has has access to knowledge today. But why are some people having larger lines and waiting time in their clinics as compared to many others? It's because it's the approach, it is the connect, it is the counseling. I think we, at the end of the day, as clinicians, cannot get satisfaction that I saw today 50 patients or 100 patients. But at the end of the day, what is the number of patients that come to us? So what brightens us up as clinicians? Every time a patient comes to us and tells us कि आधी बीमारी तो आपको मिलके ही ठीक हो गई,
दूर हो गया.
right?
Absolutely.
So that, I think that's what gives us a high, and that
Absolutely.
happens only when we have that connect. The other part you mentioned was that we may have poor time in our clinics and limited, and you make use of your time. At our center, we have 3 educators, uh, counselors, all having the connect and maintaining. But having said that, yes, there are certain aspects that the clinician still needs to do. You still need to have that conversation. And one of the things that I got an advice was, you have your EMR, and all of you are doing that now. Somewhere on the side note, so there are certain parts of the EMR you print and that goes to the patient. But there are certain aspects which you're putting down as your notes. Start putting down certain notes which you know is
Mhm.
about a conversation between you and the patient. A
Absolutely.
patient may tell you, I'm a little worried, son's admission, right? Or some other aspect, business aspect, family issues. Make a slight mention, note of that in your notes. The next time the patient comes in and you're starting a hello, and you ask, right? So
Yes.
how's that happening?
Absolutely.
And believe me, that connect will stay with you for life. So we as diabetologists are essentially glorified family physicians.
Absolutely.
The patients stay with us unless you do something
Unless
which
it.
disturbs them, they're going to stay
Absolutely.
with you for life. So have that connect. And quickly, not wanting to take away, I realize that we have 4 panelists, but and we need them to speak. But one other thing that we saw way back in Raheja Hospital during our training, it came to insulin and you start prescribing insulin, ask your patient to get buy that insulin there and there,
Right.
and try and take the first shot in
Yes.
front of you. Don't let it be for afterthoughts, which then leads to issues. So let that happen, and that changes the scenario.
Absolutely. So he's actually told you everything in very clear and a lucid language. So what I understood from what Manoj said is a good clinician is good in a C. He strikes a conversation, not a communication. We learn communication from medical school, but we don't learn conversation. That is something we should go home today. How to converse with a patient. Am I right, Manoj? That's the name of the game. A good clinician has his C's very clear. Harshpreet, you wanted to add
Just
something.
a solution which we can do is, because we don't have much time in the OPDs, we have lots of patients. So what I have done is I have made 3 TV screens in my OPD, and I have explained them in my native language, that all the patients, those who are in waiting area, knows everything about diabetes before meeting me only,
Absolutely.
because they listen from the audio visuals and everything. So that saves my time also, and that's proper counseling for the patient also. So this is the one thing which we can do in our own face value, so that patient understands is much better. Thing which sir told is about the insulin. Exactly this happens. A patient comes to me with taking a U40 insulin in a U100 syringe, and he comes to me and he's telling
Yeah,
me कि sir
absolutely.
मैं insulin बढ़ा ही पा रहा हूँ पर मेरा sugar तो control हो ही नहीं रहा है. And this was the reason that the miscommunication
We
happens
see
in
a
the
lot of
industry.
people on semaglutide oral, who actually don't know how to take it, and we see people spending money, but they're not getting results because they don't take it properly. Panika sir, if I can take 10 more seconds, he gave a beautiful example of his own, where a patient was well controlled for 10 years. Suddenly, sugars bumped up to 230. They did everything, they found out everything, nothing was found. Finally, he realized, patient was told by the cardiologist who had a change in the ECG that we will be doing your angio, and she thought, Mera bhi bypass hone wala, and the sugars went up. And it didn't come down till she was comfortably told कि ऐसा कुछ भी नहीं है, no bypass would be done. So anyway, I'm running short of time here, but then before I conclude, obviously a lot of thanks to Manoj and Purvi for getting this whole conference was hatke, a lot of different aspects were covered, made it very delicious and very nice. So thanks Manoj for being there and giving all of us a good opportunity, and a lot of thanks to the panelists for doing a wonderful job here. And before I conclude, a lot of thanks to the audience for participating very actively. Manoj, you wanted to say something?
We have a very diverse panel. Tejas Kamath from Goa, Chan Patel from Latur, Dr. Balaji from Kumbakonam, the beautiful temple town in South. I had the privilege of visiting there a few weeks back. Then Dr. Harshpreet Puteja from Ambikapur, Chhattisgarh, which I yet have to visit, but very soon will.
So you get the messages.
What I'm requesting all of you, you come from diverse places, and the largest gap in the management? I want each one of you to give your final word.
My final words would be that rather than counseling, everyone does, but we have to pledge to be a good listeners. We have to pledge here that all of us will be good listeners. And we had one consultant, Dr. Sanjay Srinivasan at Chennai. He never asked the patient to leave the room. So that is the satisfaction index at the peak level. हम लोग पेशेंट को कभी नहीं बोल रहे कि हाँ ठीक है जाइए आइए, nothing. The patient has to leave your room. He has to leave your room, and you see the satisfaction index will be 100%. So two final thoughts from my side.
So I think there are so many gaps, and one of the gaps that we routinely encounter a lot of myths as far as patient level education is concerned. The way they get the education about diabetes and all the wrong information being spread on social media, they pretend to believe their neighbors or family members what is being told by them, and tend to believe that's true, and that leads to also diabetes distress, which was the topic. So I think it's important that we spend time with the patients, making them understand about the disease. As rightly said by my co-panelist, they should be satisfied that what they wanted to know is being addressed by the physician they are meeting. And if you don't have time, maybe you have a diabetes educator or a counselor in your clinic, but patient is to go back getting sufficient information about this disease. That's more important.
Sure. So in my practice or in our practice, we have two aspects. One, as a patient side, education. Education is the thing which is lagging. That's the hugest gap that has to be filled, because I am in the tier 3 town where people come from very, very poor village where the education is very low. So we have to sit down with them and teach them. Unless otherwise you emphasize the things, nothing will be done. They are not ready enough to sit with the educator and get the things. So that's the thing. And from a physician's perspective, we are focused only on the quantity of the things, not on the quality of the treatment. So that has to change from our perspective, so including my thing. So that's
Exactly same. So the more potent point is the counseling of the patient is very much important, especially in the rural areas. Some patients, they are not properly trained, and what they think is my sugars are controlled. I have to leave the medicine. What is the need of the medicine taking for lifelong? So the first point we have to make them understand is that you have to live with diabetes happily. This is the only point which you can take care of. So this is very important. The only gap in the management is, patient understands. In the rural part area also, now money is not a very big issue because we have very cheap medicines for the diabetes also. The only point is that the doctors doesn't make them understand, but their neighbors make them understand, those who are not knowing anything. So that is the only
Absolutely.
effect and gap which we feel.
Absolutely. Very rightly said. So, Manoj, you'll agree that in any conversation, when I speak to HRs, they'll tell you body language is 90% of the communication, 10% is what you speak. And these people pick it up and decide how much increment and salaries you should get. So, how much we lack and how much we can do. So, a lot of thanks to Manoj and Purvi for this wonderful DRS. We have had a thorough, wonderful experience in the last 3 days. It was a very different Hatke conference. And thank you, lovely audience, for giving a lot of active participation. Thanks all of you once again, and I apologize for being a little late and overshooting. Thank you, dear panelists. Thanks to all of you. Have a great day.